Very well, then why don't we go ahead and call to order this cross-sector task force to address overdoses joint meeting of the Advisory Committee for Resilient Nevada and Substance Use Response Working Group together at 10 a.m. here on November the 2nd. Can we do a roll call, please?
Attorney General Ford,
Here.
Senator Dunyate, Senator Seaver Gansert, Assemblywoman Claire Thomas, Assemblywoman Jill Tolles, Dr. Stephanie Woodard.
Present.
Jessica Johnson,
Present.
Lisa Lee,
She's here for the record.
okay, Shayla Holmes,
Present.
Dr. Leslie Dixon, Christine Payson, Debbie Nadler,
Present.
Jeffrey Iverson, Gina Flores O'Toole, Eric Schoen,
Present.
Chelsea Cheatham,
Present.
Steve Shell, Angela Nichols,
Present.
David Sanchez,
Present.
Jessica Barlow, Brittany Collins Jefferson, Lil Neater Grady,
Present.
Ryan Gustafson, Dr. Kamyar,
Present.
Carissa Loper,
Present.
Catherine Loudon, Dr. Wagner,
Present.
Cecilia Maria,
Present.
Elise Monroy,
Present.
Darcy Patterson,
Present.
Pauline Sala,
Present.
Ariana Saunders, Cornelius Sheehan,
Present.
Jamie Ross,
She's here. My apologies. We're on mute. Sorry.
okay, Quinny Winbush,
Present.
you have a quorum of members of the task force.
We do have a quorum. Is that what you just said?
Yes, it is.
Very good. Okay, thank you so much. I was wondering. Okay, very well. Thanks so much. We will move on to item number 2, which is the first opportunity to set us up a public comment. Do we have anyone on the screen, on the phone, or in the rooms for public comment? I see no one here.
Attorney
I see
General
one.
for Kelly Marshall, for the record, Ms. Nadler has her hand raised, followed
Okay.
by Ms. Christine Payson virtually.
Thank you so much. Let's go that order then. Ms. Nadler, go ahead.
Good morning, everybody. Nice to have everybody together just for public record. I know I sound like a broken record here, but I hope everybody can open their eyes and their hearts and realize one thing about this whole lawsuit. We would not be having this lawsuit if it weren't for the deaths of all our children and all those that suffered from big pharma, period. The McKinsey lawsuit specifically states in it, I know we were told a million times that this lawsuit has nothing to do with the victims. However, if you go through the McKinsey lawsuit at the very bottom, on section, I think it's number 40, either B or C. I'm not looking at it right now. My dog ate it. But it does say injuries in our state. Injuries are death. And I think we have to take into consideration of victims' compensation. This is worse than 9/11. I'm seeing too many grieving family members struggle. They're on disability. They cannot afford medical care, psychiatric care. They're raising their grandkids. They're losing second children. It is the PTSD is horrific. Waking up every day knowing that you buried your child. Our children are dead every day. We wake up to that. There has got to be something on here for victims' compensation. Everything else is fabulous. Everything else we're working on is great, but there needs to be something on here for victims' compensation. And I'm not going to stop. I'm not going to stop asking for it. And that's my opinion.
Thank you, Ms. Nadler. Appreciate your public comment. And as I've said before, feel free to always raise your public comment. No one's asking you to stop. You should continue pressing that point as much as you like. Who is next on the public comment list?
Christine Payson.
Ms. Payson, go ahead. Ms. Payson? Is she on mute?
I asked her to unmute. She's still on mute.
Oh, you're still on mute, Ms. Payson. Okay.
Let's see, it looks
Lisa
like there's
Hoover. Lisa
Okay, hold
Hoover.
1 second. Hold 1 second, please.
Lisa Hoover has her hand raised as
All
well.
right. So what we will do then, I see Ms. Hoover, we'll have you go ahead and go. Ms. Payson, if you still want to have public comment, we'll circle back to you in a second. Ms. Hoover, go ahead.
Am I unmuted?
Yes, ma'am.
Okay, perfect. Hi, good morning. I'm Lisa Hoover. I am also a bereaved mother, like Debbie Nadler. I lost my son in October 2019 to an opioid overdose. It started out with the pain pills that eventually went into heroin. Cody was born and raised here in Las Vegas, lived here his whole life. Everything happened right here. It was absolutely traumatizing watching my son go through his addiction and not having any help. He left behind 2 kids, a 6-month-old son and a 16-month-old daughter who no longer have a father because of this opioid crisis and because of what the Sacklers did. And I understand you've got this money and it needs to be used to help the victims. There's too many victims. I'm meeting them every single day. You don't understand the pain that this has caused to the families. It's far reaching. We need better treatment centers. That money can go to help the kids that no longer have parents. And my heart is really in the treatment centers. My son could not get help. We reached out, we were turned away here. He ultimately spent the last 4 of his 6 months in Reno and came back here. And 2 months later, he was gone because every time we reached out for help, it's not available. There needs to be on-demand treatment. And this money should be used to help that. I lost my son because of this opioid crisis. And I don't want anybody else to feel this pain and go through this. We need to do everything we can to help and prevent more deaths that are happening. And the fentanyl is just making it worse.
Ms. Hoover, thank you so much for your public comment. We pray for you and sorry to hear about your son's loss. We appreciate the public comment and both committees will certainly keep it in mind as we move forward from a recommendation perspective. Next, we have
Darcy
Patterson.
Patterson.
Darcy Patterson, we see your hand up. Go ahead, ma'am.
Hi, my name's Darcy Patterson. I lost my daughter March 1st, 2017 from an opioid overdose, started with pills. I wanted to just make a comment that I back both Debbie Nadler and Lisa Hoover, and all the grieving families out there. There should be some victim compensation in some sort. We are those that lost because of this opioid epidemic, and we are the victims, one of the victims of the collateral damage that has been caused from this opioid epidemic. We should be receiving some compensation for all the treatment programs that we put our families in, all the children that people are raising, grandchildren that people are raising, the cost in therapy, many other things. And of course, the cost of the funeral for our children when they died. Some can't even pay for that. So I'm backing both of those, and I'm also a very huge advocate of, fighting for our victims. And the victims don't have a voice anymore. The quiet victims are the ones that died because of these opioids. And I just want to make sure that we're remembering this. I know I've brought it up a couple times, but I wanted to let you know that it's still in the back of my mind, and I'm still fighting for it. Thank you.
Thank you, Ms. Patterson, for your testimony. We likewise offer our condolences to you on your loss, and we appreciate your public comment.
I don't see him.
Do we have anyone else who would like to offer public comment? Okay, hearing none, I then will close public comment. Sir, you want to set your name for the record so we know you're here?
Stepping Andel, Tin Highs Alternative Peer Group.
Thank you so much. Okay, thank you so much. We will move on then to agenda item number 3, which is our welcome and informational introduction and review of what the ACRN, ACORN, and SURG have accomplished. From both me and Mr. Sanchez. And from my perspective, I'm gonna kick it over to my colleague to my left and ask Dr. Kearns to go ahead and chime in.
Certainly, thank you. So from the SURG was formed, and over the past year, our activities included breaking out into 3 subcommittees. Those subcommittees that were formed were the prevention, treatment and recovery, and then response were the 3 subcommittees. The SURG, the larger SURG group, met quarterly. The subcommittees met on a more frequent basis. For a good part of the year, they did meet monthly to come up with recommendations that will be provided in the SURG's report that will be due at the end of January. So those recommendations we've pushed forward, and we've included as part of the supporting documents for today's meeting.
Thank you so much, Dr. Kearns. Any comments, questions? This is an informational item, but do we have any questions or anything? Okay. Mr. Sanchez, would you like to offer an intro on behalf of ACORN?
Yes, thank you, Attorney General. The ACRN committee met all the requirements laid out in the Nevada Revised Statute, Chapter 433, NRS 433.730, and that required that before June 30th of each even numbered year, that our committee submit a report of recommendations to the Director of the Department of Health and Human Services concerning the statewide needs assessment, including the establishment of priorities and the statewide plan to allocate money from the Fund for Resilient Nevada. We did this, and we were required to consider health equity and identify any relevant disparities among racial and ethnic populations or geographic regions, and also consider special populations in the state. We also did this. We were required to use an objective method to define the potential positive and negative impacts of a priority on the health of the affected communities, with an emphasis on disproportionate impacts to any population targeted by the priority. And we were required to have at least one public meeting to solicit comments from the public concerning recommendations. We turned in our recommendations that were prioritized to the director's office, and we are looking forward to working with this task force. Thank you.
Thank you, Chair Sanchez. We appreciate the update there. Any questions or comments of Mr. Sanchez? Hearing none, we'll move on to agenda item number 4. This is also informational. Expectations of the task force operationalizing recommendations. Dr. Woodard from the Department of Health and Human Services and Senior Advisor on Behavioral Health will be presenting here. Dr. Woodard, mic's yours.
Thank you. Stephanie Woodard for the record. So I think it's important for all of us to understand that there has been a lot of work that's been undertaken by a number of different bodies over the last year, but primarily through the SURG and the ACRN. So we've actually had 3 parallel processes occurring simultaneously. The first is that there has been an enormous amount of work that has already been underway, not only over the course of this year, but for the last several years to address the opioid crisis. We have a number of different federal grants that are being used to fund a number of different activities and initiatives. And that work did not stop while we were going through the needs assessment and the state plan. Necessarily, it needed to continue. Along that same path, we've had planning happening at both the Advisory Committee for Resilient Nevada and the Substance Use Response Working Group. We've really tried to intentionally make sure that there was adequate communication between those 2 groups, oftentimes having report outs between the ACRN and the SURG in those meetings, really to intentionally make sure that not only was there communication happening, but as recommendations really elevated through the SURG, for example, those recommendations were then taken into consideration for inclusion in the Advisory Committee for Resilient Nevada. And similarly, if there were policy issues that were identified by the Advisory Committee for Resilient Nevada, those were also communicated to the Substance Use Response Working Group. So a lot of time and energy really put into these 3 really kind of tandem paths. And today, I think it's really the opportunity for us to bring all of this together. There has been a lot of concern and question around the amount of time and energy that's been put into some of the planning, and necessarily so. The needs assessment captured more than 40 existing documents, including quantitative and qualitative data, as well as implementation plans, community-based needs assessments, and others that resulted in the needs assessment. That was then used to support the development of the recommendations, and those recommendations are forthcoming in the state plan. And we have also heard that we have a growing amount of concerns around the risks directly to our communities around the influx of fentanyl into our illicit drug supply, resulting in increased risk for overdose at the community level. So now that the 2 groups have not completed their planning, but the majority of that planning has ceased, and we are awaiting the state plan to be released. We're expecting that state plan. It's going through an internal review right now. We really felt like the timing was right to bring the 2 groups together and really start talking about what can we do now to help to fortify our communities and reduce risk for continued harm as it relates to overdose. So in preparation for this meeting, we had established some goals. So the first goal is to determine necessary action to reduce the risk of overdose in Nevada's communities. The second is prepare responses for the state and local jurisdictions in the event an increase in overdoses occurs. And then the third is to provide technical assistance, guidance, and resources to rapidly implement best practices to reduce risk of overdoses, enhance capacity to respond to events, and recover should such overdose events occur. We have seen this happen in a number of our communities across the state and nationally. So what we know is that the more prepared our communities are and the more prepared our state is, the better we will be able to detect should an increase in overdoses or what we would consider a spike in overdoses occur, And then we could rapidly respond at a state level and a community level with resources, hoping to obviously contain the risk to the degree possible, and hopefully result in saving lives. Next slide. So just some expectations as we spend time together. The goal here is not to add increased work or duties to already quite overtaxed groups. These groups, the ACRN and the SURG, have committed a lot of time and energy and really strategic thinking to get us to where we are today. So we want to use this time together to really make meaningful progress forward. So consistent with other open meetings, we will be using a consensus-based model for decision-making. That's also really predicated on group participation. So really offering opportunities for discussion so that we can all come to conclusions that we agree on, especially when it comes to next steps. That there may be opportunities for work between meetings to make sure that the time in meetings is absolutely most productive. That we all work together to stay on task and stay on time. There's been a lot of time and energy already devoted to similar groups, and so we want to make sure that we honor everyone's time so that we can use the time here as productively as possible. And that we collectively will help to identify the action plan, and that action plan must leverage existing resources to the greatest degree possible. As I'd mentioned before, there's been already a pretty significant investment in both state and federal funds to support the work that's being done at the state and local levels to address the opioid crisis. So we want to make sure that we are optimizing that federal funding whenever possible. That also means that we have to think strategically about how to develop actions at a state level. So those are some of the expectations. Next slide. Some additional expectations, and this is consistent with the legislation that established both the SURG and the ACRN, is that the activities must be evidence-based and demonstrate effectiveness. And this includes messaging. We want to make sure that if there are recommendations that are coming out of either the Joint Task Force, the SURG, or the ACRN, that all are really based in evidence. That we consider implementation science. My shortcut to understanding implementation science is ready, willing, and able. We have to make sure that if we are moving forward with an activity, that there's a readiness. We also understand that at times there can be difficulties with a willingness, right? You have to have lead agencies and other stakeholders that are really willing to come to the table and do the work. And then ability. And ability sometimes has to do with resource, but sometimes it also has to do with the training and technical assistance necessary in order for success to come about with the implementation. So want to put that out there for us to be considering, because one of the things that we have seen is that more often than not, it's not about having the funding to do whatever the activity is. We have had federal funds before that we've pushed out to community partners to help to do this work. And what we often see is that we don't necessarily have a readiness for those dollars or the ability or capabilities in order to make use of those funds. So thinking strategically.
And Dr. And that's a key point that I think is worth us keeping in mind as we move forward, because, as you've indicated, we can be ready to do it, or pardon me, we can be willing to do it and even ready. But if we're not able to implement it, then we will continue to have missed opportunities to assist folks. So what's been contemplated, maybe you can speak to this, or maybe we can just have a conversation around it. What's been contemplated to help community organizations to be more able to implement assistance once we are able to provide funding to them federally or otherwise, or from this lawsuit, for example?
So it's a great question. And I'll reveal a little bit about what's in the state plan. Okay. So when we had a chance to take a step back and look at the majority of the recommendations that came into the state plan, what became very clear was the need for training and technical assistance. So you will see recommendations such as implement XYZ evidence-based practice, right? We know that in order for us to implement that practice, we will have to have community partners that are ready and able to be able to implement that practice. We also saw a lot of need for continued training or technical assistance. So what our plan is to support regions by providing training and technology transfer coordinators to help to support reaching up to national organizations or state subject matter experts to be able to help with that implementation. So there are addiction technology transfer centers, prevention technology and transfer centers. We have the opioid response group, the opioid response network, the ORN. There are a ton of federal organizations that have been funded to be able to provide training and technical assistance. What we find more often than not is that it's the connectivity to those national organizations to support the training and technical assistance. The other thing that we've seen fairly consistently is that we may have an organization or a community provider that really wants to implement something new or participate in developing a new service, but they don't really know what they need in order to be able to do that. So by being able to come alongside community partners to help them assess where they are related to readiness and capabilities, and then supporting them in getting the training and technical assistance needed for them to be successful is part of that goal.
Well, what about the actual existence of the resource? We heard in public comment that one of the aggrieved parents had to send their child to Reno because they couldn't find services locally. I suspect that's an issue in many parts of our state where you don't have a local facility that can help in the opioid substance abuse issue. So is there anything contemplated relative to providing resources or developing resources and in those types of places?
Yes. So we've been working with the Centers for Medicare and Medicaid to develop an 1115 substance use disorder waiver. Essentially what that means is that until we have that waiver in place, the only funding that has been available to the state is primarily federal block grant funding that comes through Department of Health and Human Services, the Division of Public and Behavioral Health, to the Bureau of Behavioral Health, Wellness, and Prevention. So it's only been a very limited pot of funding that we've been able to use for residential treatment and community-based withdrawal management services. What the waiver allows us to do once it is in place is it allows us to maximize federal matching funds through Medicaid to be able to bring down those federal funds, then allowing the other federal funds that we have through the block grant to expand the availability of treatment. Parallel to this, we're also working on recovery housing. Okay. So recovery housing has been largely absent. You often hear about sober living homes, oftentimes unregulated. And so in partnership with GoEd, we are working to develop recovery housing statewide to help to continue to expand the availability of those supports.
Well, that's promising to hear. And thank you for the update on that. You talked about the federal funding component. I think public comment we hear, the question is whether some of the opioid settlement funds can be utilized toward that effort. And I think I could be wrong on this. Part of that answer is contained in the needs assessment, whether it has incorporated certain recommendations that have come from SURG and the ACRN. Are we out of order to have you speak on whether there are efforts or the needs assessment contemplates using settlement funds to do any of this as opposed to waiting on federal funds?
Yes. So I'm happy to speak to it. And actually, in the legislation, it is required that we do not supplant, but supplement what is already being funded. So part of the presentation that we have this morning is an overview of our state opioid response federal grant. That federal grant is to the tune of $16 million a year. And those federal funds are specifically for treatment and prevention activities. And so what we want to do is we want to optimize those dollars first to be able to really move to implementation of those primary recommendations within the state needs assessment. That will allow to be able to address those areas that either we don't have sufficient funding for in our federal grants, or our federal grants are restricted and we would not be able to use those dollars.
Yeah, because when you talk about the waivers, I mean, that's not something we concern ourselves with relative to the settlement funds. You don't have to concern yourself with going to get a waiver from the federal government before you can use funds in certain types of. Okay, thank you so much. I didn't mean to cut you off in the middle of your presentation there, but I thought these were timely questions based on, at a minimum, public comment we've heard today, but also comments you've heard over the course of our meetings in the SURG committee. So please go ahead and continue.
Yes, and I appreciate the questions and the opportunity for continued conversation. So just a few more expectations. That we do continue to have a focus on health equity and addressing disparities. It has been a core component of much of the deliberation and discussions that has taken place in the SURG and the ACRN, and we need to continue to really be intentional in bringing that lens forward. We do have a balance that I think we've consistently needed to try to strike between the need for urgent action with planning. And that there is an opportunity towards the end of the meeting to be able to establish a cadence for the joint task force for future meetings. Next slide. So to be able to move the recommendations to actual implementation, we have to make them able to be operationalized. And in order for us to do that, especially for those that can be considered for immediate action, I think it's important for us to have situational awareness with data and current activities, because again, we've run 3 different parallel processes simultaneously, and many of the recommendations that came from the ACRN and the SURG are already underway. So getting a snapshot of what is already occurring, I think will give this group a good idea as to where maybe some of the gaps are and where some additional effort could be put to help to move some of those other recommendations forward. So really making sure that we're using the foundation that's already been set with the ACRN and the SURG for continued planning. And so to be able to move from general recommendations to a much more detailed action plan. And those action plans typically are going to be coming from those who are already doing this work. Next slide. So an example of operationalizing a recommendation, and we did provide a list of some recommendations that were pulled out of the needs assessment and state plan. And what you will see is in most cases, they're incredibly high level and very general. So what we need is to identify who the lead agency is. If this work is already being undertaken, who is doing that? And then if they are doing that, what are the actions that are taking place? I think also accountability is a really important piece to making sure that continued efforts remain and that we have the opportunity to evaluate how effective the current interventions are. And when we talk about implementation science, it's also important for us to identify that every implementation plan will have some risks as well as some facilitators, the things that enable us to be successful in that implementation. So this is just kind of a very high level overview of the kinds of things that we will be talking about later on today after the presentations. One area that having an opportunity to look at this again with fresh eyes, even just this morning, that I would suggest that we add is specifically some information on the evidence base so that we can continue to move that kind of information forward along with the recommendation. So the recommendations in and of themselves had to be evidence-based, but I don't think we've done yet the job of linking the actual evidence to the recommendation. So this would allow us an opportunity to do that. Next slide. So an overview of the materials provided in anticipation of today's meeting. There is a committee membership list. What we have found before is that it's really important for people to know who is on the committee. We have a whole range of subject matter experts, people who are in the field doing this work day in and day out, as well as representatives on the committee who have lived experience. Everyone who is on each of the committees is an equal and valued participant. And so that committee membership list is really for all of the attendees, so you know who are your fellow peers on the committee. We also provided a suitor data report on all state data from 21, as well as an infographic. And Elise Monroy and others will be going into in-depth detail on some data for us later today. We've also provided an overview of the state opioid response grant summary, as well as the opioid antagonist saturation plan. And Michelle Berry will be joining us today to go over that in detail. And then a subset of the priorities that were developed between the ACRN and the SURG that are in the state plan. And those have been provided as they had been identified for possible immediate action. Those that are either already underway or have been identified as key best practices to help to fortify our communities in our state should a spike in overdoses occur.
For the edification of the committees, can you remind us where we are on the state plan?
Yes, so the state plan is pretty much done. It's in the internal QA review. And so we were hoping to have it done by today. We're anticipating it over the next couple of weeks, but that is, it's pretty much done.
Okay, all right, very well, thank you.
And so I'm hoping Michelle Berry from CASAT is available and on the call. I invited her today. I think she will do it much better justice than I in the detailed overview of the state opioid response plan, as well as the opioid agonist saturation plan. Primarily because if you look at a number of the recommendations from the state plan, one is specific around access to naloxone in our communities. So wanted to give her an opportunity today to just briefly speak about the Nevada State Opioid Response Plan, as well as the Opioid Antagonist Saturation Plan. So Michelle Berry is from the Center of Applied Substance Abuse Technologies at the University of Nevada, Reno, and she is the Senior Project Manager for the Nevada State Opioid Response. Michelle, are you with us this morning?
Yes, I'm here. Can you hear me?
Yes, we can.
Okay, great. Hi, my name is Michelle Berry. I'm, as Dr. Woodard said, with CASAT in the School of Public Health at the University of Nevada, Reno. And with me, I do have my colleague, Morgan Green, who is also with CASAT, and she's a program coordinator and really works around overdose education and the distribution of naloxone within our state. I think that the handout that was provided to you includes the needs assessment and the opioid antagonist saturation plan. And that's attachment 8 that was submitted with the SOR3 application. And so the majority of the information that came from this application, we were limited by page numbers. So in the first portion, it's the needs assessment. A lot of that information was taken from the state needs assessment and subsequent data resources that we were able to pull from. And it is in line with what Dr. Woodard was saying, that naturally additional resources are needed in the state, that there are unmet needs and gaps, and that the needs assessment has identified what those are. And it is in line with the priority areas that SOAR will be moving forward in SOAR 3 to address. But regarding the saturation plan, I can have Morgan go over some of the ins and outs of how that came to be and what our anticipated target numbers are and how we are going to begin moving this into the community. And I believe Dr. Woodard, or Dr. Wagner, who is a member of the ACRN, was also one of our subject matter experts that helped us to pull all of this information together. So I did want to give her some acknowledgement. But Morgan, I can hand this over to you.
All right. This was really developed in conjunction with OD2A and Elise's team, both the state OD2A as well as Southern Nevada Health District's OD2A, as they are the primary distributing center in Southern Nevada, as well as Carla Wagner and her team. And really, this was an opportunity for us to look at what we really needed to get out there into the communities for the people who needed to have it in communities. What was the best way to reach that population? And so our target goal is to have naloxone present at 80% of witnessed overdoses within our state. We do not currently have the infrastructure to do that. So this plan is really that infrastructure development so that we can have those partners in our communities that has naloxone available, that makes it easy access, reduction of barriers, to increase the number of people who will have that on hand if a crisis should occur at any point in time. One of the primary target areas is really looking at reaching our BIPOC communities and ensuring that they also have equal access, that we're speaking the correct language in all regards. So making sure that we have materials that are translated, materials that are vernacularly accepted for those communities. And then continue to work with identifying those hotspots. So really looking at where the highest risk locations are that overdoses are occurring, and really working with those communities themselves to ensure that we have something that is accessible in those areas. So through all of that, we set it up to have several goals and activities to work towards that infrastructure development, as well as looking at really who the primary targets are to develop these relationships with, starting with emergency rooms, making sure that people who are coming into the emergency rooms, whether it's for medical emergencies, have the ability to walk out with naloxone without having to, again, work through all those barriers, working with our Minority Health Equity Coalition, working with our tribes, and making sure that they are also receiving the resources that they need. And then working with, especially since Nevada is really well known for its high risk activities, so to speak, really working with our casinos, our sex industry, all of that to ensure that they are also in the mix for all of this and developing those relationships. So really, again, reducing that stigma, reducing those barriers, and increasing those partnerships. So through that, we are looking at increasing the amount of naloxone that's in the community easily, about 30% each year. So we're looking at increasing for year one up to 40,000 units, year two, 55,000 units. And that is working towards our goal of that 80%. So if you guys have any questions, please feel free to reach out to us at CASAT. We're more than happy to do that. And we love the partnerships.
And these dollars are coming directly from the state opioid response grant.
Well,
So this is not, these are not funds that are needed from the Fund for Resilient Nevada.
That was actually going to be my question. Where are you getting the money to pay for it? Okay.
Yes.
Yeah.
It was a requirement from our notice of funding opportunity that we had to set aside a minimum amount for naloxone and the opioid antagonist. So this is what we have determined to be reasonable to build and sustain the infrastructure.
This is
So,
oh,
go ahead. Yeah, go ahead.
thank you. Thank you. This is David Sanchez, chair of the ACRN, and I was just looking over the information that you provided us, and after hearing your informational piece on the saturation plan, and I didn't realize that what you guys have done so far is you have found funding for that. So as this task force looks at a portion of what is missing in the community, it says here that over the period of time, which is 21 or 20 to 21, there were roughly 28,000 kits that were distributed, and there would need to be an increase of another 87,000 roughly kits distributed. This is something that I've had on my mind as this task force was coming up, and I'm wondering if you, through your work, you would see some type of, if the task force is able to support getting more kits out into the community, if that would effectively save lives.
So again, that's really back to that infrastructure development. So it's not that we don't have the product, it's that we don't have the partners that are in those locations that need the naloxone to be available. And so really it's building those relationships and building those partnerships to get that naloxone where it needs to be. So that's really what our goal is to continue working within our communities. So for the task forces, it's really identifying who those partners are. That's really what we would absolutely love the assistance with. And at that point, then we can really, build this piece out.
Thank you.
Yeah, I think there's even a prefacing remark to that. You use the phrase building relationships is probably creating them in the first place. They don't exist. I mean, we don't have enough centers and providers and those who can even receive the naloxone, they help pass it out. So it seems to me that we need to be creating those forms. Maybe not we, but certainly local communities need to be working toward creating the folks that we can actually work with. That's not asking for a response. I'm just thinking out loud here. But what I do have a question about is, are we contemplating saturating into the schools? We've heard Ms. Nadler say this several times before. I've heard from the community members as well that we're especially concerned about youth use of opioids. And so what's the plan, if at all, to utilize naloxone in the schools and try to get it distributed there?
So it was legislation that was put into place in the last legislative session that requires schools to have naloxone on site. We have been, over the last 2 years, we have been working with the various school districts to ensure that they do have naloxone present. We've also been working with the charter schools in many of our districts to ensure that they also have both training and naloxone present. And school police have been carrying naloxone for many years. So that is ongoing. But that's definitely something that is continuing to grow and that acceptance.
Yeah, you mentioned that you needed to increase, I'm sorry, I'll come to you just a second, in 80% in terms of the naloxone use needed in the communities. Does that incorporate increased presence in the schools or no?
Yeah, so to reach that saturation point of a minimum of 80%, this is what we would need. And so yes, that does include more naloxone units being provided in schools.
Mm-hmm.
Okay, all right. I had a question here or a comment. Go ahead.
Yeah, I have a couple of comments. Hi, Jessica Johnson, for the record, SURG committee member. My question about the schools and this maybe is, would the naloxone be there to deploy, to use if someone was experiencing an overdose, or for the availability of young people and families as like a distribution site? I think as I'm thinking, putting my implementation science hat on, I think that's the opportunity that as I was actually driving over here today, thinking about this meeting, I think that's one of my remaining questions. Would we be encouraging schools to be distributing naloxone to families or young people that need it? Or would it be increasing the number of identified administrative staff that could deploy naloxone should an overdose occur? Does that make sense?
It does make sense.
Okay. I think that's a question that's on my mind as we think about implementation and thinking about the great work that Ms. Berry and Ms. Green have done across the state. So I think that would be helpful. An opportunity to provide, oh, sorry, go ahead.
Oh, no, and then Michelle Berry for the record, but I think that is also something that we want to continue doing, pushing out overdose education and really broadening that message, and then alerting individuals where these distribution sites are. So if they're not comfortable with taking it home the day of the presentation, then where can you access it? But at least be aware of what some of the signs are and what risk looks like. So continue education.
So on this point, I know she has other questions, but I want to say on this point, and I'm glad you mentioned the alternative of making a distribution site. That was not what I was contemplating. I mean, but I'm not adverse to it, but I was thinking about it being on site for use in the event an overdose occurs.
Yes.
I'll leave it to the people who know better than I do on whether it's appropriate to have a school being a distribution site for it. But relative to the training associated with using naloxone, this is an esoteric question of sorts that I'm just throwing out loud. Are we doing staff development with the schools? Or are we presenting? Is someone presenting? Not we. Is someone presenting to the teachers and administrators during staff development at the beginning of the year, or something along the lines of what opioid issues look like and how to use naloxone? Is that how they're being trained, or do we know? Okay.
Yes, that is happening. Every coalition, so there are prevention coalitions covering every community in Nevada. And there has been long-standing relationships between the prevention coalitions and every school district in Nevada. And oftentimes, especially in our smaller, more rural communities, the coalitions are the ones who actually go out and do staff training, who are the ones, and I'm stealing from my presentation, but yes, absolutely, in multiple communities, the coalitions are the ones who are training school staff, school nurses, hospital staff, police departments, and absolutely those connections already exist. The issue is saturation. Is it happening in every single school, in every single community? Not to the extent that we would all like to. If we all had the unlimited amounts of money and unlimited amounts of time, it would be happening. But in all of our communities, those relationships already exist.
Well, kudos on that. I think there's a lot of people don't know this. You know, that they want activity in the schools and don't know that it's actually happening already. We could augment it, we can improve it, and I think it's important that we continue to do that. But people should hear this right now, that we are active in the schools. Naloxone is available in the schools. Staffs are getting trained in the schools to utilize this. And I think that's a very important note for those of us on these committees, those in public comment, and any media listening to this as well. This is happening. So I think it's, I want to say that out loud. Go ahead, man. You had two other questions. Oh, I'm sorry.
Sorry, Jamie Ross, for the record, that previous comment.
Oh, it was Jamie Ross. Yeah, you're very good.
We do have some folks online. Ms. Nadler and Dr. Wagner have their hands raised.
Okay, so Ms. Nadler and Dr. Wagner, I'll come to you in a second. Let me finish up with Ms.
I'm going to pivot away from schools, so
Okay.
I hope that's okay. So two other, Jessica Johnson, for the record, one of my roles at the health district is that I work with a committee of folks who do naloxone distribution in the community, some of my colleagues. So I'm privileged to have some conversations around maybe some of the system barriers that we might want to think about in this work. So the first is distribution in emergency rooms. I saw was on this plan. What I'm hearing from folks who are working to expand this is that ERs, when folks are in the hospital, they're giving a prescription for naloxone and not necessarily the actual medication. So I think the opportunity for medication delivery bedside would be very important, so that people are walking out with the medication in hand, not a prescription for a medication, in order to reduce that barrier. We know once someone who's experienced an overdose, the likelihood of them experiencing one again is high. And two, some of the work that we've been able to do has been encouraging our local casinos and entertainment groups to either supply naloxone through nalox boxes or some other type of entity. And Dr. Kearns has been incredible in doing research nationally about liability. There's a concern about the provision of naloxone and what that liability might look like. And sharing that research with them has been helpful, but I'm wondering if there is some type of a letter or an advisory that could go out to entities such as casinos or other private business entertainment groups or locations where we know there are hotspots that could accompany the training itself. That would be beneficial for reducing barriers to getting naloxone availability in these places. Other communities have looked at public libraries, for example, had very big success with nalox boxes at public libraries. City of Chicago has done that work in a really impressive capacity. So those were just two areas that seemed like actionable barriers that I wanted to bring up. Thank you.
Thank you. Okay, let's move. Ms. Nadler.
Thank you, Attorney General Ford. You know that's my biggest passion is with the schools. Several schools I've talked to, they don't have Narcan. I've had teachers reach out to me and tell me their kids are using heroin in the bathroom. Is there a way that the Nevada Board of Education are they involved in mandating this in the schools? Because I've heard so many mixed stories. CCSD told me, from the person in the health department from CCSD told me it is mandated. Nevada State told me it's not mandated. Obviously, we know with fentanyl, we are losing kids right and left, and it's happening in the schools. And I think a lot of it somehow we should mandate this in the schools. Is there a way to mandate it? Because right now they have the choice to use it. I think they're under the impression that they have to be medically trained to use it, which the police officers years ago were under that impression before we mandated them carrying it. I'm just seeing too much. That's number one. Jessica, thank you for bringing that up. That's a very good point. A little boy that finally got into detox at Southern Hills Hospital was there for 2 days. That's all Medicaid would pay. They let him out. All they gave him was sleeping pills, gabapentin. They didn't give him Narcan, and he's out on the streets again. So Stephanie, to bring back to your point about working with Medicaid, I'm sorry, my hand was raised a while ago. To bring back your point about Medicaid and working with the different rehabs and resources around, it's still happening. What happened 10 years ago with my son, with Lisa's son, with Darcy, our kids, the kids on the streets now, it's impossible. The beds are full at Crossroads, so they go to Southern Hills. That's the only other place. If they have Medicaid, they're there for 2 days and there's no follow-up. This kid is in the streets again. He was given sleeping pills and gabapentin. What are you working with Medicaid to increase their time in a place, or to get them into a place once they detox? I know that was a mouthful there, but
yeah, that was quite a bit there, Ms. Nadler. And by the way, you keep coming in and out, muted a little bit, and clear on the other, so maybe you can work on the phone there. I do want to mention a couple of things. I got 3 other folks in the queue, and then we need to move on the agenda. But Ms. Nadler, as regards mandating it in the schools, my understanding is that the law is a may and not a shall. And so the mandate will need to come either, I don't know if it can come from the Department of Education or not, but likely it needs to come from the legislature. That's a legislative fix that our legislators who are on this committee might consider listening to. I don't know. It's difficult, especially because if it's an unfunded mandate, it's very difficult to require that type of to make that type of requirement. So I just wanted to mention that out loud. I know you had a Medicaid question. I don't know if anyone was prepared to answer it right now. If we want to try to address it offline.
Okay, I'll address it offline.
All right, she'll address you offline. Okay. She'll address it offline with you. Okay, very good. Okay, here's the order, and then we're going to let Dr. Woodard finish her portion. We'll move on to the agenda. I have Dr. Wagner, Lisa Lee, and then Mr. Mandel. Dr. Wagner.
Hi, thank you. Carla Wagner for the record. Can you hear me? I'm calling in on a cell phone.
Yes, we can hear you.
Okay, great. So I have a few things to say about this. I am a professor in the School of Public Health at the University of Nevada, Reno. Naloxone distribution has been part of my research agenda for over a decade at this point, so I'm so thrilled to see this plan and was really happy to work with the CASAT team on it. So first, I just want to commend them on their great work and their thoughtful work on this plan that is looking at existing efforts and opportunities. I think we're at a moment in terms of naloxone access in the state where we are moving from a kind of universal strategy, get naloxone into everybody's hands as fast as we possibly can, to a more thoughtful and targeted strategy about where does the naloxone really need to be to make a difference. And so one thing I want to emphasize in the language of the plan that the SOR team put together is that the goal is to have naloxone at 80% of witnessed overdoses. It doesn't do us any good if naloxone is under everybody's kitchen sink and not at the place where overdoses are happening. And so I think this plan is really an effort to be very thoughtful about getting naloxone into the right hands at the right moment in the right places. And so sometimes that is a place. Sometimes that is a person. And sometimes that is a person who is carrying naloxone back and forth. And so I want to emphasize that part of the plan, that the goal is have naloxone at the scene of the overdoses. And so, for example, when we talk about different venues, we have to think about where are the overdoses actually happening and is the naloxone right there? Because if we have to travel 3 or 5 or 10 or 15 minutes to get it, it's not going to make a difference. It has to be where the overdose is happening. To Jessica Johnson's point about naloxone distribution in the ERs, I have a study that's running out of a few ERs, and there is this issue, and I think it's probably a solvable issue about whether ERs have an outpatient pharmacy that can actually dispense take-home medication. And that seems to be the barrier in some places, is that the ER itself doesn't have the pharmacy that can send patients home with medication, then they have to send people with a prescription. I think that's a solvable problem and one we can work with hospitals on. To Jessica's other point about the casinos and the entertainment groups and fear of liability, this is something we've been working on for almost 15 years now to assure people about the liability concerns. And so I think her suggestion of a letter coming from the AG's office to reassure organizations about what the law says is brilliant. We have to keep communicating. Nevada has a very good law around naloxone access and liability concerns. We have to communicate that from trusted sources so that people know what their protections are. And then finally, if I could, I just wanted to kind of ask Morgan a question and give her an opportunity to talk about forms of naloxone. I didn't see it in the plan, but we have had conversations before about intranasal versus injectable naloxone. There is an enormous cost difference. And so making sure that the kind of naloxone that people want, that is most affordable, that is most cost effective, is available to them. And then I also know Morgan has some information about kind of emerging other forms of opioid antagonists that are going to be on the market. So I want to give the team an opportunity to talk about those issues because I think they are important nuances to the plan that have implications for finance and for acceptability in the community.
Thanks, Doctor. Morgan?
Yes, so there is expected to be 2 or 3 new opioid antagonist medications that are hopefully supposed to be being fast-tracked through the FDA right now and should be available around February. They have been developed specifically to target fentanyl, as we've been finding that those overdoses that are related to fentanyl is taking an increasing amount of medication to reverse, which is not really all that helpful when most people are truly only carrying 2 doses. So really increasing the availability of some viable options to allow individuals to have that choice and have that ability is important. We also know that there is a variation in regards to that injectable versus the nasal naloxone itself in terms of who's comfortable with using it. We find that generally regular population, so most of the everyday person on the street is more comfortable with the nasal, but that doesn't necessarily translate to the individuals who are highest risk or being available to the people who are highest risk. So really having that access to the injectable naloxone, which others may be more comfortable with, or they've had more luck with the injectable naloxone in reversing fentanyl-related overdoses available. So we have been trying to work with specifically around Track B and Southern Nevada Health District's vending machine component and getting those vending machines out that do carry both types of that naloxone. We haven't budgeted aside from the injectable in the current budget for certain limitations, but that is something that is continuing to be discussed in terms of ensuring that that is available.
Thank you so much. Thank you. Okay, Ms. Lee, do you still have a question or a comment? I know she's in a doctor's appointment.
Hi, everyone. Sorry, Lisa Lee for the record.
Yeah, go ahead, Lisa.
Okay. Okay, thank you so much. Morgan, thank you for stating everything about the injectable naloxone. I had a couple of points to make on that. Going back to the schools, the one thing I would like to remind prevention coalitions is to also don't forget about Nevada State charter schools. I did a naloxone training yesterday morning for a Nevada State charter school that's located in downtown Reno at kind of ground zero of a lot of stuff that happens there, including, community groups doing serving food and whatnot. And so they really are at ground zero. And they were super appreciative to have that training. So don't forget about, folks that are outside of the school districts. And my second point is, especially if they're in really high risk areas. And then my second point is just to reiterate kind of what Morgan said, that it has been my experience. I got like 3,553 injectable doses from the Clinton Foundation, thanks to Ryan Hampton, and have been distributing those. I'm almost out. And I will say that the people I distribute to mostly prefer the injectable naloxone. They are stating that it is easier at reversing overdoses. And also there's a lot of evidence that if you slowly deliver, through intramuscular injection, you don't send a person into precipitated withdrawals and you reverse their overdose. So I just want to say that that education also needs to get out there, because a lot of folks are really, like, I hear this a lot, like, please don't Narcan me. But it's like, yes, but if you're not breathing, you're going to be, given naloxone. But I feel that we should learn some lessons from harm reduction organizations and overdose prevention centers across the world, in that when you slowly deliver naloxone, it is less likely to send someone into those gnarly precipitated withdrawals. And so I think that should be added to our naloxone distribution plan. So in other words, getting naloxone out to the people who are there reversing overdoses, which is unlikely to be a professional person, no offense. And secondly, that it is delivered in a way that causes the least harm to the person receiving naloxone. Thank you.
Thanks, Lisa. All right, we did get one more comment, but we really got to move on after Ms. London goes. But Mr. Mandel, and then we'll go Ms. Loudon, I think, and then we'll move on.
Giuseppe Mandel, tonight alternative group. Just a quick question, because it's back to the schools again. And thank you guys for all the work that you do. I do appreciate it. It's getting the naloxone into the right hands. So, the staff and the nursing and everything, it's great, but is there any way to implement where there's training for the students? Because the overdoses are going to happen at the parties and in the bathrooms where there's no nursing staff, school police, or anything like that. So is there any information to educate the children and the students in the schools and distribute to them? Because those are the ones that are going to save the ODs. The overdose is going to happen at the parties. They're going to happen, not at school or in the school bathroom. And so is there any way that we can remove that barrier to get the school boards on board to implement training just for the students, even if there's no staff involved? Because they're the ones that are going to prevent the ODs.
Jamie Ross, for the record, I think that's a great question and something that there is some community interest in. It's just a much bigger lift. Currently, the law is for nurses and nursing, the nurses' aides, what we used to call them, in the schools, and there's no current law that would even allow leave behind, is my understanding, so that could be then distributed. So I think it's just a multi-step process. It's definitely not a bad idea, just more barriers than currently we have the ability to cover. That wouldn't be a quick solution. That would be a long-term solution, I would believe.
So I guess then my question, is there any way to get a quick solution to at least try to get distribution sites to, even if the schools don't want to get on board, get some kind of announcement to get the students on board? Because I mean, one life, I mean, I know what we're talking about time frame, but the time frame is running short.
Yeah.
Like it's right short, and we're talking about young kids.
This
Like
is
they-
Carla
they
Wagner,
feel-
for the record. I'm sorry to interrupt, but if I could just add a point to that. I think, as far as I understand in state law, there is no legal barrier to providing naloxone to lay people. That's what the SB 459 was in 2015. Whether it can happen through the schools or whether it must happen through the schools is sort of a different issue. But my understanding is there is no legal barrier to training young people and
Right.
equipping young people with naloxone right now.
I think that's right. And we have another comment here. Go ahead.
Jessica Johnson, for the record, I'm curious in reviewing the action plan materials, if that's been an opportunity for development of communications and focusing some of that communication on young folks and where they might be able to either get access to naloxone or receive naloxone in the mail. Might be a quicker version than some of the administrative red tape. I just wanted to offer that idea and review of the action items.
Look,
I think the
your
legal
point
framework
is,
exists now.
yeah, and I'm not even certain you need a legal framework, just thinking out loud here. I mean, your point is exactly right. I mean, I have a high schooler. My last one's in high school right now. And I know that he knows of folks who engage in this precarious activity, and to be sure, it's not at school. So getting information to them, look, here's the deal. Our schools are such fertile grounds for combat and fight among parents these days. Trying to convince a school district to say, I'm going to now reach out directly to kids and get them naloxone might cause a problem. That doesn't mean there can't be a voluntary circumstance whereby a provider says we're going to hold a voluntary training at Acme High School, and any parent who wants to bring their child and learn about it can. That kind of stuff, right? Those are probably quicker solutions than trying to make some legal requirement or remove any perceived legal obstruction to that. So anyway, that's all to say. I hear what you're saying, and you're exactly right about this. I do think you got a lot of folks who are brainstorming on ways to get naloxone, Narcan into the hands of folks who can be on site for 80% of the overdoses, which would be at some of these high school parties you're talking about. So, okay, look, y'all, I am not trying to stifle conversation, but we are stuck on this agenda item, and I keep getting public additional comments. We can do it. That's fine. I just want y'all to know we'll be here. So with that, we got two more. I want to be certain that Ms. Loudon, your hand came down. Does that mean you no longer have a question or a comment?
I know that Dr. Woodard is aware of what we're doing in Washoe County School District with the naloxone in our area substance abuse coalition joined together Northern Nevada. So I was going to have her give my comments, but Washoe County School District is collaborating with our substance abuse coalition joined together Northern Nevada. We have trained people in naloxone and are distributing it. We also are using through Damani Ranch High School is giving some fentanyl awareness, and parents will be able to receive information and materials through that. So I was trying to be brief, but there are a lot of things happening in schools. I think one of the key things is to make sure that teachers are trained and other staff members are trained to be alerted if a student looks like they're sleeping or needs some support. So one of the things we have done is created a training to further empower our teachers to be aware. But it definitely works. It's been used on our campuses and it has saved lives.
Thank you. Ms. Monroy. Is that right?
Yes, thank you, AG Ford. So this is Elise Monroy for the record. I feel really compelled to point out the fact that we have been talking about how to get naloxone in schools for over an hour. And by looking at the data, which was provided to everybody, a minority of people that died in the last year were under the age of 25. These conversations should always start with data for this reason. This has not been like an evidence-based way to spend our time. 80% of people that died by fatal overdose in 2021 died in their home, not in a school. and most of them were between the ages of 25 and 44. So I think it would be in the best interest of the folks that are actively dying by overdose that we maybe try to move along from the school conversation. I'll also point out that the overdoses that happened, that precipitated this meeting today, I do not believe they were school-based or youth overdoses as well. So again, just feel compelled to say that these conversations should always start with data, and had this conversation started with data, I don't know that we would have spent an hour talking about how to get naloxone in schools. Thank you.
Thank you for your comment, Ms. Monroy. Ms. Nadler.
Yes, Debbie Nadler for the record. Do we have actual data
here? Because I've tried to look for it. That shows the overdoses in school. I personally lost a cousin last October, and she bought it from school.
and it's happening? Our kids are being offered in school.
It's called preventative. We want to prevent them before they,
start to use. All our kids are experimenting now. It's happening all over the place, and that's why school is such a big issue. Nationwide, it is the number one death. Nationwide, go to the CDC, go to SAMHSA, go to NIDA. It is for teens. So school is the place. They're buying it at school. And I'm sorry, that's my 2 cents worth on that. Thank you.
Thank you. Okay, our very last comment on this, Ms. Lee, and then we're going to move on to the next agenda item. Ms. Lee.
Thank you, Attorney General Ford. Lisa Lee for the record. I'm sorry, I was trying to pull up the data on non-fatal overdoses for this age group in Washoe County. It is significantly higher than the deaths, which is great. But I also feel like the 2 or 3 deaths that happen annually are 2 or 3 deaths more than those parents would ever dream of. And so, and also looking at the non-fatal overdoses, the hospitalizations for an overdose, it is in the 200s. I'm trying to find that data right now. Sorry, I just sat down at my desk. But so I also want to think in terms of non-fatal overdose occurrences and not just who's showing up in the death data, because we also know that a previous non-fatal overdose is a significant risk factor to a future fatal overdose. So in that way, I do think that this is a data-informed conversation. Just wanted to throw that out there.
No, thank you so much. We're going to close the conversation on this one, and I'll just say as we transition that, look, this opioid issue has a lot of facets to it, a lot of faces to it. A lot of people have different perspectives and approaches and priorities. So these conversations are going to sometimes be longer than we would imagine, but it's a very important conversation to have, and I want to try to be conducive to us having these conversations so that we can get as much information out as possible to inform those on areas, even if it's not, as she indicated, death-related. If we're trying to prevent overdoses in the first instance, we need to be having conversations around those who may be more susceptible to having them anyway. So let's move on. Let's move on to agenda item number, where was that? 5 now. And here's the plan. We're going to do agenda item number 5, take a 5-minute break, and then come back and push through the rest. All right? Agenda item number 5. Dr. Kearns is going to report on current trends occurring in Nevada. Kearns and Ms. Payson as well.
Sure. Yeah, I can go ahead and start. I just wanted to preface my comments to say that these are not necessarily trends that are going on in Nevada. I recently attended a fentanyl training that was put on by the National Association of Attorney Generals. And so a lot of these comments are national, but also happening here within our state. And one of the first comments is that from 2021 to 2022, there was a 200% increase in fentanyl encounters by U.S. law enforcement. So our law enforcement are seeing fentanyl more commonly. Different agencies are seeing slightly different drugs, but CBP said that what they are currently seeing is more fentanyl-laced pills as opposed to the powders. So that's a little bit different. There was discussion on looking at the current production and encounters with law enforcement with fentanyl and the trends in the overdose death data that we will, as the fentanyl production increases, we will likely see obviously an increase in overdoses and overdose deaths. But the models looking at both of those items predict that we could see a doubling in overdose deaths within the next couple of years, going as high as 145,000 overdose deaths. So a lot of work to do. There was a presentation by an emergency room physician out of San Diego in California, who is also a subspecialty in addiction medicine. And she really pushed that we need to have public health and public safety partnerships. Those are critical. In San Diego, they have what they call CREDO, Community Response to Drug Overdoses. And she said a couple of things that have come out of those CREDO meetings is that often the emergency departments can really inform law enforcement and first responders on what they're seeing and the people coming in who have overdosed and the drug trends. And then on the other side is that law enforcement can also inform our practitioners on trends that they are seeing in novel drugs that may not be as prevalent. But one thing that she really highlighted is that a lot of the hospitals in California were not aware that fentanyl is not on the drug screen testing that's done in hospitals. In order to be tested for fentanyl on someone who's coming over, that has to be sent out by most of the hospitals, and that can be a 3-day turnaround. So one of the things that they did in California is, I believe she said it was Tyler's Law, is that hospitals will include fentanyl on their panel of drug tests on patients that come in, as opposed to those being sent out, so that we have better data on what's going on in the hospitals with fentanyls. There was also discussion by her on what you heard from Morgan Green, that there's some new opioid reversal drugs. Naloxone's the generic name, Narcan, which is typically 4 milligrams. And then this new one is Colacto, which is 8 milligrams, really targeting fentanyl. And she said often in the emergency department, they do use naloxone drips to reverse the fentanyl overdoses, and to Lisa Lee's point, to keep the person from going into withdrawal. Also presented at this was that national data does say that 45% of overdoses that occur are witnessed by a bystander. So getting naloxone in the hands of those who can help to have an impact is important. One thing that I really want to highlight, there's a group there, it's called Shatterproof. It's a nonprofit advocacy and policy organization. And when I spoke to them in the break, they said that they really compliment the work that has been done within Nevada, and that they often hold Nevada up as the model to other states for all of the legislation and programs that we have implemented. And my takeaway, unfortunately, from this conference was things can definitely get worse before they get better. And that's why all the work that we're doing is very important. I'll tender to Christine Payson.
Ms. Payson.
She should be.
Hello.
Ms. Payson, are you? Yeah, we can hear you. Go ahead.
Okay. Hey, Ray.
Alrighty. So,
There's an echo.
I muted one. Okay, there we go. Gotcha.
There you go. Go ahead now.
How's that? Does that work?
Yes, ma'am.
Okay. So, wanted to cover a little bit more on fentanyl and the law enforcement aspect of this. One of the key components, of course, in combating the overdose crisis is to remove the illegal substances from our communities through law enforcement actions. To say that the amount of illicit drugs pouring over our southern border is mind-blowing is really an understatement. It's tremendous amounts are being seized every single day. And you can see, sorry, I'm having a little trouble with my notes. There we go. AB 236 changed the sentencing guidelines for drug offenses, and I think an unintended side effect or consequence rather is that it failed to separate fentanyl out from other illegal drugs, and we believe that the penalties need to be greater for fentanyl as opposed to other types of drugs. You can see, except for marijuana, and highlighted there, 100 grams or more, but less than 400 grams is considered now low-level trafficking, and anything above 400 grams is high-level trafficking. There's no mid, there's no separation by type of substance. Next slide. That's my slide.
It's up. The next slide is up.
Okay, but it's not one that I had in what I sent, so I'm not sure where
Oh,
that came
okay.
from.
Right.
I see what she just put it in a different. Yeah, it's the same information. It's just a different chart. But this is what the Customs and Border Patrol are using, a conversion chart to show dosage units, so that you can get an idea of just how deadly fentanyl can be compared to the other drugs, which is why we think it needs to be separated out. Nationwide, officers reported over 1,400 seizures of fentanyl during just traffic stops. Just traffic stops for highway safety, 1,452 seizures of fentanyl. And you can see, using this conversion chart and the 400 grams that is required for high-level trafficking from the previous slide, 400 grams could kill 269,048 people. If this subject is in possession of one less gram, it's then low-level trafficking, but it still has the potential to kill 265,051 people. Next slide. And this is just give you a visual of what these seizures look like. They're taking place daily, nationwide, and right here in our own backyard. The top left photo is from September 6th, a traffic stop up in Ely, Nevada. And the lower right is from September 28th. It was in our neighboring state of Arizona, where the DEA Phoenix Division seized over 8 million fake fentanyl pills during a nationwide operation that lasted several months. And across the U.S., more than 10 million fentanyl pills and 980 pounds of fentanyl powder were seized during this one operation between May 23rd and September 8th. And that is enough to kill 36 million people. Next slide. And finally, we all have our ideas on how these funds, when we hopefully get them, will be allocated. And we need to have more funds allocated to fund the personnel and the resources to investigate and prosecute drug-related crimes. We'd like to see an expansion of the overdose response team throughout the state. Detectives on these type of teams would respond to an overdose scene and attempt to identify the source of supply through sophisticated investigative techniques. You can see the goals here of that team that operates with Las Vegas Metro is to utilize a cross-disciplinary close collaboration between public health and public safety at federal, state, and local levels to reduce drug availability, to prevent overdoses, and to make treatment and recovery available to victims and families impacted by these overdoses by working with our health partners and providing linkage to care. And one other place we'd like to see some funding go is toward an independent medical examiner that can provide the report in these cases. Toxicology is key for these cases to be successfully prosecuted, and they require a report that will give the specific cause of death in an overdose case. And we'd like to see some funding go for that independent expert. And that is all I have. If anyone has any questions for me.
Thank you so much. Questions? Yes, ma'am. Go ahead.
Hi, Jessica Johnson for the record. Thank you, Dr. Kearns and Ms. Payson, for a great overview on this issue. It's definitely very concerning. Ms. Payson, I had a question. I appreciated the legislation at the beginning of this presentation and was curious if if there are recommendations on the table, I guess, around amounts. I'm familiar with some legislation out of Colorado, so I was reading up on that this morning. So I didn't know if you were prepared to speak to that or happy to even take it offline and have a more in-depth conversation. I'm curious if intentionality is something that's being considered, if folks are knowingly or unknowingly furnishing fentanyl to individuals, or what the other considerations might be in terms of sort of how public health and public safety might think about this together. Thank you.
Ms. Payson, for the board's application, I have a bill, as do others in the legislature, to address fentanyl weights, to lower them for prosecution purposes. So that conversation is ongoing about what the right weight would be. Colorado is obviously an example that we can look at, but I just want to let everyone know about that. Ms. Payson, do you have a response?
Reference intentionality. I can tell you that from speaking to both state and federal prosecutors that handle these type of cases, there's been very few that have gone forward here in our state because they are so difficult to prosecute, and they really want clear and convincing evidence that the person supplying the drug is fully aware of the lethality. They are looking for clear, convincing evidence that they know exactly what they're selling and providing, not someone who just happened to bring a few pills to a party and is a co-user. They are looking at dealers and traffickers.
Thank you, Ms. Payson. Oh, go ahead.
One follow-up. Thank you. Jessica Johnson for the record. A quick follow-up. Thank you. That's very clear. Do you surmise that if the changes to the legislation or the weights go forward, that will change the prosecutorial perspective? Like if it, no, so if it's lower, I guess is what I'm asking. Sorry.
Because in Mounts, you're looking at possession or trafficking. In an overdose death case, you're still going to be looking at someone that is clearly knew what they were providing.
Yeah, it's a different issue altogether. Well, maybe not altogether, but yeah, I would agree that I haven't heard necessarily of a bill that looks to change intent requirements on the prosecution side of things, but certainly many bills that address the weight issue that was on the other chart there. So, all right, I have a couple of people here. I have Dr. Wagner. Ms. Lee, your hand went up and down, so I'm not sure if you do have a question, you'll be after Ms. Wagner. Otherwise, it'll be Ms. Nadler, and then we'll move on from there. Dr. Wagner.
Thank you, Attorney General Carla Wagner, for the record. I understand around this issue that people are under enormous pressure to do something in many ways about these increasing concerns about fentanyl in the drug supply. But I think this issue in particular is a place where public health experts and law enforcement experts, the perspectives diverge dramatically. From a public health perspective, increasing prosecutions and penalties for drug trafficking is not an evidence-based strategy for preventing drug use or preventing drug overdose. We know that incarceration is actually a public health risk factor for things like increasing risk of overdose, increasing transmission of bloodborne pathogens like HIV and hepatitis C, and very serious disruptions in our community to social determinants of health like housing and employment and education and childcare. So from a public health perspective, when I think about what do we need to do about this emerging threat of fentanyl, I think my public health colleagues would agree, we have to double down on evidence-based strategies that have been shown to protect the public health. So that's things like evidence-based drug prevention education and teaching young people how to recognize and respond to an overdose and prevent them and understand what's in the drug supply, and the things we've already talked about in terms of increasing access to treatment and increasing access to naloxone. So when we're considering finite resources, it is my opinion as a public health expert on this topic that we need to concentrate those resources on prevention strategies that work, and that there are very serious harms and an emerging research literature showing the harms of increasing penalties and how that can actually exacerbate some of the concerns that we're seeing in our community.
Listen, it's a great point. And this is one of those circumstances where I think the criminal justice system and the public health systems have a little conflict, to be sure. The purpose of the criminal justice system is to punish a wrongdoer, put him in prison, rehabilitate him and restore him back to society. That rehabilitation and restoration might take place in conjunction with some public health approaches while he's in prison. I'm just making this up, right? But the point is, I think these aren't mutually exclusive. At the end of the day, the criminal justice system is looking to get these folks off the street because they are, in fact, leading the deaths relative to the amount of fentanyl that we're seeing out there. But Dr. Wagner, your point is well taken, and I think we will be hearing from you during the testimony time period in the legislature as you raise this issue for the legislators to continue. I get it. Thank you so much for your input on that. Ms. Nadler and then Ms. Lee.
Yes, thank you so much. Yes, I agree. Prevention is the best method we can take right now. But I do have a question about it. I know Attorney General Ford, and I applaud you for this. You were one of the, I believe, 15 attorney generals across the country. There might have been more who signed on that fentanyl is a weapon of mass destruction. And I've been looking and looking and looking. I'm not sure what that means. All the attorney generals have made, all the attorney generals who've declared fentanyl as a weapon of mass destruction. What does that look like in our state? So we've defined it as a weapon of mass destruction. A bomb is a weapon of mass destruction. Do we let somebody who's let off one bomb, because that was their first time to let off one bomb, go and wait till they set off 4 bombs? I'm not sure what this means, that we've declared fentanyl a weapon of mass destruction in our state. What does that look like?
No, I appreciate that. There's been no definition. Let me be clear. The letter was an intent to bring to the attention of the nation writ large that this is an issue. The phraseology catches the attention, to be sure, and this is something that we're focusing on in our state and with colleagues across the nation. So I appreciate you acknowledging that. But there's no codified statutory definition of that phrase in our Nevada law, nor will there be, at least not from legislation that I'm putting forward. So I appreciate that, Ms. Nadler. Ms. Lee.
Okay, thank you.
Thank you, Attorney General Ford. Lisa Lee for the record. As a person with lived experience who's lost so many people around me for the last 28 years, and as a scholar practitioner in public health, I do want to reiterate what Dr. Wagner brought up, and as well as Jessica Johnson's concerns. There was a report put out, and I'll just read a few of those highlights of the report. So since 2011, 45 states have proposed legislation to increase penalties for fentanyl, while 39 states have passed or enacted such legislation. To date, none of the states that enacted harsher penalties for fentanyl have demonstrated a reduction in fentanyl-involved overdose deaths because of these new laws. It goes on, and I'd be happy to send the full report. Some of the recommendations from public health are to expand and protect 9/11 Good Samaritan laws, expand community-based naloxone access and distribution, expand opioid agonist treatment, improve drug checking, which we do not have here. So my point to that in drug checking is that we don't have mass spectrometry around the state where people who use drugs and people who do low-level sales can even know what's in the drug supply. So that's an unfair advantage that law enforcement has over people engaged in the sale of drugs. Another recommendation is authorize supervised consumption sites on the state and local level and fund pilot injectable opioid treatment as an option for some people with chronic heroin use disorder. And that's based on some research that's been ongoing in Canada on injectable buprenorphine. So these are some of the strategies coming out of public health. And I did just want to remind this body that many of our drug laws historically since 1914 and the Harrison Act have been incredibly racist and have criminalized Black and brown communities in disproportionate numbers. And so as we think about advancing racial equity in public health, I want us to be very mindful and intentional about what we propose and ensure that we're thinking about unintended consequences of furthering these racial disparities in our mass incarceration systems. Thank you.
Thank you. I appreciate it. This is going to be an issue that I think is going to have a lot of discussion. There's no question. My bill is not the only one that's going to be percolating. It may not even get a hearing because the others will have bills on this issue as well. So hopefully we will have experts from this group at that table as well, working with people on the language that can satisfy both the criminal justice side of things and the public health side of things. And I'm confident we can get that done. Okay, last comment, and then we'll move on.
Woodard here.
I'm sorry. Oh, Dr. Woodard. Those two more comments. Dr. Woodard, and then Ms. Sala.
All right, thank you.
Yes.
Stephanie Woodard for the record. So it did dawn on me that we do have members from the ACRN that have not necessarily participated in the larger SURG meetings or the subcommittee meetings. So I just wanted to bring forward that this conversation and presentations by a number of people on this committee have been heard by both the SURG and the subcommittees. I'm on the response subcommittee, and there's been quite a bit of dialogue around this issue specifically. And I do want to thank Dr. Wagner because she came up with some terminology that really caught everyone's attention, so much so that we've actually established it as a guiding principle for that subcommittee. And we'll be making that recommendation to the larger SURG committee in our upcoming meeting. And I'll just read it to you because I think that it does help to capture the nuance of these conversations, which is to harmonize public safety and public and behavioral health responses to substance use in our communities and state. It is an aspirational guiding principle, but it is something that I think we all need to keep at the top of mind as we are endeavoring in these discussions and coming up with solutions to how to best address these issues in our state. So I just wanted to put that on record and make sure that everyone, including those in the ACRN, were aware that that is some ongoing discussion and movement at the SURG level.
Maybe I heard you tell me that before, but I sure feel like I got this one right, because that's what I've been saying. This is a harmonization issue, right? Criminal justice and public safety. We got to get it figured out, and I think we have an opportunity to do it, and hopefully we'll get it done in a way that will move the ball forward. So, Pauline, go ahead.
Thank you, AG Ford. I think that as I hear this conversation and I represent the juvenile justice field, that I would hope that we could have some balance between the criminal justice field and public health. I don't think if we go on either side of the spectrum, we're going to be successful, because sometimes the criminal justice field is the entry point for these people. And it doesn't matter. It doesn't mean that we have to put them in prison or jail, but what it means is we can connect them to services that are so needed. I think the juvenile justice system went through a reform 10 years ago and became more balanced. We are doing more specialty courts in the adult system. We are doing more diversion. We make sure that our kids in the juvenile justice system get the right services at the right time. So I just think that if we have a balance, sometimes we're the entry point that we can connect people to the right services. And it doesn't mean they have to be imprisoned, long sentences. It means we can just help get them where they need to go. So I just want to throw that out there, because I keep hearing the public health side, which I absolutely support. But the criminal justice system too, I think, can be a port of entry.
Thank you so much, Pauline. Okay, that brings our discussion on agenda item number 5 to a conclusion, unless Dr. Kearns or Ms. Payson have anything else. Okay. All right, hearing none, then why don't we do this? I said 5 minutes. I'll give you 10. So actually, I'll give you 12. Let's come back at 11:55, please, and pick up and try to run through the rest of the agenda, everyone. So we'll see you at 11:55.
Do we sign off or stay on? If
No. Just mute yourself and turn your camera off and come back at 11:55. All right. Okay, let's call everybody back in. We are at the 11:55 hour. We good?
Yes.
Okay. I hope you had a good break. I went and got me some more coffee and ready to go. So number 7, is that where?
Yes.
Yeah, number 7. Six. My bad.
Six.
Informational report on overdose data. Ms. Monroy.
Thank you, Attorney General Ford. Elise Monroy here, Nevada Overdose Data to Action Program. I'm actually going to do a joint presentation with our program's epidemiologist, Sean Thomas, and he's actually going to get us started, and I will be batting cleanup for Sean. So go ahead, Sean, whenever you're ready.
Thank you.
Thanks, Elise. My name is Sean Thomas, for the record, and I'm an epidemiologist at the University of Nevada, Reno School of Public Health. And I'll give a brief presentation on our overdose surveillance data. Next slide, please.
Next one.
Great. So the Nevada Overdose Stats Action Program is the state's main source of opioid and overdose surveillance and prevention funding. And it's currently in its 4th year of grant funding from the CDC. And in Nevada, many different types of systems are used to describe the burden of overdose in the community. These are not all the systems, but these are the ones most utilized by our program or other agencies. The first are hospital-based systems, which include hospital billing data for charges billed in the emergency department or inpatient hospital encounters, primarily using ICD-10 diagnosis codes. There's also syndromic surveillance, which is a near real-time way to detect changes in emergency department visits, including visits related to drug overdose, to inform a public health response. This system collects de-identified information on patient chief complaints, ICD-10 codes at discharge, and other information. And most facilities in Nevada report less than 24 hours, and about over 90% of emergency departments across the state report into the system. There's also data from emergency medical services, which comes from ImageTrend, which is a statewide surveillance system utilized by state EMS, which has just been recently leveraged by our program. Then there's also ODMAP, Overdose Detection Mapping Application Program, which provides near real-time suspected overdose data across jurisdictions to support public safety and public health efforts to mobilize an immediate response. Then there's death certificate information from the Electronic Death Registry System, or EDRS, that reports overdose mortality in the state. This source relies primarily on ICD-10 death codes. On average, the cause and manner of death are available 2 to 3 months after the death investigation, but may take longer to be put into a usable form for state and local health departments. And lastly, there's the State Unintentional Drug Overdose Reporting System, or SURG, which uses death certificate information, but also information from the coroner medical examiner to capture detailed information on toxicology, death scene investigations, including such things as route of administration, as well as other risk factors they may be associated with an overdose. Some of these additional risk factors are such things as past substance use or misuse history, if the person received treatment for pain, if they were a veteran or were experiencing homelessness, or recently released from an institutional setting like hospital or stuff like that. And I'll be showing data for the 3 different systems in blue stars on the slide. So next slide, please. So this slide is going to show trends for the past 5 years from 2017 to 2021. Okay, yeah, thank you. Yeah, you can just click through those. The first here on the very top is looking at rate of suspected drug-related overdoses from syndromic surveillance. During this time frame, there is a 17% increase for suspected drug-related overdoses in Nevada among residents. And if you look at the bottom, that second figure below is showing the rate of drug overdose deaths in Nevada from that second system, the Electronic Death Registry System. And from 2017 to 2021, there's a 32% increase in the rate of overdose deaths. And kind of to briefly summarize the demographics, since I only had 5 slides, in 2021, between both systems, the highest rates of drug overdoses in the ED and deaths were among males, Black non-Hispanic persons, and those aged 25 to 34 years old. Next slide, please.
Hold on. Can I ask a question about that slide?
Okay. Yes.
So are these charts looking at the same data such that we should be concerned that one chart says a 70% increase and the other says a 32% increase?
So the one on the top is more of the non-fatal drug overdoses, and the one on the bottom is fatal overdoses.
Okay, that's what I need to know. Thank you.
Mm-hmm. Great, so now talk a little bit about that third data source, suitors. Going to talk a little bit about the substances involved and the circumstances surrounding overdose. And suitors, these deaths are for drug overdoses that were found to be unintentional or had an undetermined intent, so they won't usually include, they won't really include suicides. In 2021, suitors detected on average 2 to 3 substances for each decedent, really highlighting that we should not be just focused on one type of drug, but polysubstance use. Opioids and stimulants are the top 2 classes of substances involved in overdose deaths. 64%, including at least one opioid, 61% of deaths, including at least one stimulant, and over 1 in 4 deaths, including both. Among opioid deaths, 56% involved fentanyl. And for the stimulant deaths, the majority was made up by methamphetamine. And I couldn't fit all the polysubstance use patterns in these slides, so we do have quite an abundant amount of polysubstance reports on our website if you wanted to learn more. And then with that second part, with the circumstances, so SUITRS contains information on those circumstances surrounding overdose, which are events that occurred prior to overdose that in certain instances may have been related to the overdose. Such things as a recent release within a month from a prison, jail, treatment, or hospital facility, or if somebody had a bystander present at time of overdose. These circumstances include information that is not documented in any other data system and should be utilized by prevention, treatment, harm reduction, and other agencies when designing programs and interventions in the state. A breakdown of these circumstances can be found in our reports. I believe one of them was also attached as one of the documents for the meeting. But based on 2021 data, here 78% of decedents had at least one potential opportunity for linkage to care prior to death or implementation of a life-saving action at the time of overdose. So these events include such things as like a recent release from an institutional setting within a month of death, having a previous history of having a non-fatal overdose, having a history of a mental health diagnosis, if they ever received substance use disorder treatment, or if they had a bystander or witness present when the fatal overdose occurred. And I also wanted to quickly highlight in the bottom right, the most prevalent circumstances among the decedents where opioids and stimulants contributed to death. To Dr. Wagner's point earlier on place in regard to naloxone, it was actually 86% of overdoses here on the slide. 81 was a typo, but just to show that the majority of these overdoses are occurring in a home setting. It may not be the decedent's home, but it is in a home setting. 6 in 10 had a bystander present at the time of overdose, and 1 in 3 had a mental health diagnosis. Next slide, please.
Hold on, can I ask a question on this?
Sure.
The 86% of overdoses occurring in a home. I got a couple questions related to that. I'd like to know the 62% of overdoses had a bystander present. Is that, I guess I'm trying to understand if the 81% of those that died in the home, how many of those had a bystander present? And of those, I don't want to reopen this kind of worms, but were school-age children, high schoolers, middle schoolers, maybe around, had they had access to naloxone? Could they ever helped? You know, I'm just wondering if there's some level of analysis associated with at-home deaths, especially as it relates to who the bystander is, and especially if the bystander is a school-age child who could have used some training, for example, on naloxone or whatnot.
Yeah, thank you for your question. So the first part of that, we've done some analyses looking at overdoses in the home and bystanders present, and I believe it was about 2/3 of overdose deaths. We primarily looked at fentanyl, though about 2/3 didn't have a bystander present. And as for who these bystanders are, we'll definitely do a little bit more digging. It's more qualitative because it's within the narrative that the coroner medical examiners get and they put into the system. But typically it's going to be family. We could look closer at the school-age children. It was about 13 school-age children in the SUITRS system in 2021. So we can do a deeper dive in there to see if there was anyone present during those deaths.
Okay, thank you.
Mm-hmm. Thank you. Next slide, please. So just some key takeaways from our data before Elise talks about the limitations and gaps. Overdoses have increased and continue to remain high in Nevada, driven by an increase in synthetic opioids like illicitly manufactured fentanyl, as well as psychostimulants like methamphetamine. It's clear that overdoses are impacting persons of color and younger populations disproportionately, primarily younger adults. Polysubstance use based on our mortality data is also common among decedents, primarily with prescription illicit opioids and stimulants. And lastly, unintentional drug overdoses can be prevented with over 3 in 4 decedents having a missed opportunity to prevent their death. Elise, let you take the last slide.
Thank you, Sean. Elise Monroy for the record. I will remind the committee that the information provided in our presentation reports on deaths that happened in the last year, so for 2021. But the recent spike in overdose deaths in Las Vegas that prompted this meeting, very little has been shared about those deaths. Very little is known about those deaths. There are a few formal data sharing agreements in place with law enforcement and public health agencies. So we have to wait for people to die to have information to inform overdose spike risk. There are public health agencies and programs in Nevada that do have really good working relationships with law enforcement agencies, both at the state and local level. But there are very few formal agreements for data sharing in place. So information is not standardized, and often information that is shared from law enforcement to a public health or prevention partner cannot be redisclosed publicly. Additionally, to Debbie's point, if overdoses are happening in school settings, then that information needs to be shared with public health programs and agencies so we can adequately respond. Nevada needs better biosurveillance of the drug supply so we can better understand and respond to what substances are causing harm and death in more real time. The OD2A program is currently working on a needs assessment to understand how testing and biosurveillance are being used to inform risk. In our preliminary findings, we have identified a few critical issues that may be impacting Nevada's ability to drive to a quick confirmatory surveillance system. And before I read these, what these limitations are, I think that these things, these limitations, at least some of them are going to need to be addressed in order for this cross-sector task force to develop its action plan, specifically identifying substances involved in overdoses quickly, and then connecting public safety. So these are things that I think will need to be addressed sooner than later in order for response to happen. So first, Nevada is one of only 2 states with no statewide crime lab. However, however, in August, the Interim Finance Committee recently allocated, I think it was ARPA funding, to establish a statewide crime lab within the state public health lab. So currently, Nevada has 3 crime labs that serve each region, but each of these labs work independently. So testing panels may not always be standardized, which means labs may be using and reporting on different testing protocols when running tests. In 2020, the Nevada Office of Traffic Safety published a gaps analysis of the state's current forensic toxicology lab. Excuse me, I'm getting tongue-tied. Okay. So the report by the Office of Traffic Safety noted that inconsistent testing panel and thresholds across the 3 labs in the state was a significant gap. Specifically, the report notes that 3 labs use different testing panels and test for a different number of drugs, ranging from one lab testing for 30 and another testing for 60. The Office of Traffic Safety reports that there are differences in the cutoff values used to distinguish positive and negative results. So this also will impact the interpretation of results. While standardizing this analysis will help to ensure fair treatment of drivers when the labs are testing for antemortem testing, it also helps the state to ensure that, sorry, I just need a minute to catch my breath. I don't know why I'm having such a hard time. Attorney General Ford, I'm sorry.
All good. Take your time. We're good.
Okay. Okay, I'm going to move to the next, the next gap. We have unstandardized, 3 unstandardized labs. There you go. Okay. Also, Nevada's existing crime labs are forensic in nature. Through our needs assessment research and talking with labs, we understand that the role forensic labs play in the current system is to use science for the purpose of criminal proceedings, not public health surveillance, or to inform the public of potential risks. The lab representatives that we actually met with believe that they are in no way compelled to share data with public health agencies to inform response because they are forensic labs. Next, there are a limited number of formal data sharing agreements in place between crime labs, law enforcement, and public health programs. We know that some of our local prevention and overdose spike response stakeholders enjoy informal information sharing relationships with their local law enforcement, but these agreements are largely relationship driven, and that's inconsistent with building a sustainable system. Finally, we have heard that many seized drugs in Nevada are not tested. In Nevada, seized drugs are tested if and when a case goes to trial, and we know how long that can take. We've heard that this could be a result of lab capacity and or funding. If seized drugs are tested in Nevada, that data is sent to the National Forensic Lab Information System, or NIFLIS. NIFLIS data is reported quarterly, and while we have not had a chance to take a deep dive into how local crime labs are funded, we did find that forensic testing is at least in part supported through the county's general fund. Nevada Revised Statute 4.457.575 requires court fees to be levied to pay for controlled substance analysis. If a county can only recoup costs for analysis when court fees are levied, it may result in limited testing resources. So finally, that concludes our presentation. I appreciate the patience and grace, but additional data and resources from our program can be found at nvopioidresponse.org/OD2A. And Sean and I, hopefully more Sean than me, are happy to take questions. Thank you.
Listen, thanks so much, Elise, for that report. You raised some very startling statistics from my perspective. Maybe I should know. I don't recall what IFC has done. You just said about a state forensic lab. Can you repeat that?
Yes, Elise Monroy for the record. The August interim Finance Committee allocated funds. I think it was the ARPA dollars, COVID relief. Okay. I'm not really sure. I can confirm, but it was whatever that marathon IFC meeting was, funds for an expansion of the state public health lab. And that those funds were intended, at least in part, to help build out capacity for a statewide crime lab. I'll also say that the Overdose Data to Action program is currently working closely with the state public health lab to purchase a mass spectrometer, so we can start kind of building processes and protocols for that public health surveillance sampling with the lab. Okay,
thank you. And I know others have questions as well. Let me chunk this one out real quickly for you. I wonder if there are people on the phone who can speak to the rationale behind the differing, some people test 30, some people test 60, and then the weight numbers or percentages, whatever the phraseology you used, are different for purposes of, I don't know the words you used, Elise, but what you're talking about with some people testing for 60 types of drugs versus 30 types. What is there a rationale that we know? I understand the importance of a standardized testing, so to speak, but maybe there's a rationale someone can explain as to why right now there are varying techniques or standards for testing. Anybody know? Am I making sense?
Yeah. You're absolutely making sense. I don't have the answer. The best one that I can think of is that the current crime labs just serve each county's jurisdiction. So they function to serve their own county and their own needs. But again, our program is working on publishing that needs assessment. And we do have additional information from the labs in there. But we have really smart people. Dr. Kearns is really familiar with lab testing. And I know Dr. Wagner too, with her time in San Diego, might have some insights.
All right, thank you. Well, so Dr. Wagner chimed in, but before I go to her, even to answer my own question, I'm going to go in order. Deb Nadler, you chimed in with a hand raised, so go ahead.
Yeah, number one, to answer your question, I know in California, as far as the labs are concerned and how they test, it's cost. It has to do with cost. There's certain, like I know West LA County, as far as the toxicology reports, they have to request different levels. Each level is more expensive, and I guess it's a standard that's set in each specific county on what they test for. To answer your question, I know that's what they do in California. But my other question is, thank you so much, Elise, for this great presentation. But I still have questions regarding y'all's statistics compared to nationwide statistics. I can't say the word statistics on our state, when I know in the CDC and in NIDA, it's showing in 2021 that 69% of white males were overdosed. And it's also showing different numbers, and it's also breaks down the kids even more. So I'm curious as to where your numbers are coming from. It's like we see so many different numbers. Like, how do we know what's real and what's not real?
Debbie, are you referencing fatal overdoses or non-fatal overdoses?
Fatal.
Okay. The suitors, well, Sean, do you have a response for Debbie before I confuse everybody?
Sean Thomas for the record. Thanks for your question, Debbie. So in regard to what we reported out on the demographics, those are rates. So the ones that you probably have on that report, it's going to be more of based on total counts. Among overdoses, both non-fatal and fatal, it is highest among white non-Hispanic persons. But when looking at more of a rate per population, because white non-Hispanic people in Nevada and nationwide are going to have the highest proportion. But when we're trying to look at specific populations, we're really focused in on looking at those rates, because if we compare white non-Hispanic persons compared to Black non-Hispanic persons, always going to be white non-Hispanic persons that will typically have a higher number. But as for rate, it's going to be higher among Black non-Hispanic persons.
And if I can,
so you're talking about overdoses altogether, non-fatal and fatal?
Yes.
Or okay. So that's the difference that I'm looking at. Is that correct? I'm looking at fatal, and I should be looking at all, correct?
well, you'll want to look at, this is Elise Monroy for the record. You'll want to look
Thanks,
at
Elise.
all, but also there's a difference between a rate versus a count. So
Okay.
I was a liberal arts major, so sometimes it amuses me that like this is the job that I have and this is what I'm doing, but it's really important that we look at rates as opposed to counts, because if 100 people overdose in Washoe County, where the denominator is going to be 500,000, but 100 people overdose in Lincoln County, where the denominator is 5,000, it's a completely different situation. So the rate helps us to standardize the situation across communities. So that is why the number, when you look at a count, is going to look higher as opposed to looking at a rate. I will say the OD2A program uses a smaller number for our rate calculation. We use 10,000 as a standardized rate calculation as opposed to 100,000, because for years we took data into rural communities and they saw the rate calculated per 100,000 and they said, that's not our data, that's not our problem. What are you talking about? So that might also be, Debbie, what is feeling confusing is you have a rate versus a count, and those numbers are going to look different, but we have to use the rates so we can make sure that our rural communities that are going to have smaller counts or are like our, when we're looking at populations and minorities, where those communities are going to be smaller, are going to feel the pinch more than in other communities. So.
Gotcha. Totally understood. Thank you for that clarification. I see too many numbers. Thank you.
Thanks, Deb. And thank you all for that conversation. That was great. Dr. Wagner.
Thank you, Carla Wagner, for the record. First of all, I just want to commend Elise on her epidemiology explanatory skills there. She's right on, and those concepts are hard to grasp, and she just taught them very well, so I'm quite impressed. I wanted to make a comment about your question, Attorney General, around the consistency in testing. And just point out that what Elise and Sean and their team are doing in some ways is actually quite heroic, because they are taking data that are made available and generated for certain purposes, and they are trying to transform them into surveillance data that give us a standardized picture of what's happening across our communities. But in doing that, they're taking data that were not intended for this purpose. So the issue of the toxicology panel that's run on by a medical examiner or a coroner, those things vary jurisdiction to jurisdiction, because the data generated by that tox panel are used by the coroner and the ME to write death certificates, right? They're not designed for the purpose of surveillance. And the same is true with non-fatal overdoses that are presenting in emergency departments, or that we're trying to count in other ways, for example, by looking at how often EMS responds to an overdose. The data points that are generated for clinical purposes and often for billing purposes. And so in an attempt to make use out of what's available, people like Sean and Elise and these programs are really trying to transform those data into common data elements that can be used for other purposes. And this might be an opportunity where these coalitions and the state and these kinds of data sharing agreements that Elise is talking about could step in through a coordinated effort to standardize. But in principle, in my experience, the reason that you're seeing these inconsistencies is because the data are not generated for the purpose of helping us count the things we're trying to count. We are making the best use out of what's available to us. And there are some holes in that, as Elise pointed out through her talk about limitations.
You know,
I
got a couple.
Standardization and coordination.
I got a couple thoughts. I'm over here smiling because I'm surrounded by all these smart folks. All y'all talk, and this is great. This is the reason why I really think we have an opportunity to solve some real big problems here. There's too many smart folks engaged and involved in this for us not to be able to come up with some solutions. First off, but secondly, so we call it. I called it an inconsistency among jurisdictions, but maybe it's not inconsistent at all, because it's consistent for what the jurisdiction is asking for, and what it is that Elise is trying to do is, as you've indicated, quite heroic in standardizing it for a different purpose that we can all utilize it for our purposes here, but all these smart folks to figure out how we can address opioid and other substance use related issues. So thank you for that explanation, Dr. Wagner. That was very helpful to me. All right, Ms. Johnson.
Thank you so much, Jessica Johnson, for the record. This question is for Sean. I was wondering, in the SURG data that you have from 2021, what type of toxicology testing is being done? I know you mentioned fentanyl and some of the other areas. I had the opportunity a couple of weeks ago to go to the National Harm Reduction Conference, and one of the adulterants that they're seeing in proliferation on the East Coast is xylazine, and I'm just wondering if there's any evidence at this juncture from SURG or other data systems that you're privy to. Are we seeing that at all in the drug supply in Nevada? Thanks.
That question, Sean Thomas, for the record. So for your first thing with regard to the toxicology panels, they typically, both our coroner medical examiners in North and South, they do order expanded toxicology panels, which do a whole host of opioid related substances, as well as some fentanyl and fentanyl analogs, as well as those, to some effect, also those emerging novel substances as well. In regards to your question about xylazine, if I recall, I believe it was 1 or 2 cases in suitors that tested positive for xylazine. So, and it's kind of stayed consistent. I believe the first report was in 2020, and then we saw it 1 or 2 again in 2021. So that's kind of where it's at, not like an explosion on like other parts of the country, but we're starting to slowly see maybe a few cases.
The only thing I'd add to that is the Overdose Data to Action program actually pays for the expanded toxicology testing. We partner with the state's 2 coroner medical examiners, and our program pays for that, but the CDC limits the amount of funding that we have, and the coroners need more, and we are limited by our federal funding. So just wanted to put that on the record.
Thank you.
Thanks. Yes, go ahead, sir.
I thank you very much. Just Stephanie Mandel for the record. And this might go to where it's cross substances, where it's stimulant and opiate, and the data that you're pulling, and maybe to the amount of how many, how much of the amount is in the test. Is there a separate category for that for say where it says fatal and non-fatal overdoses, or like say poisonings? Where, I mean, how much is that is a low level of say fentanyl, or other substances in a high level of cocaine where say the user didn't know that they were taking fentanyl?
Sean
Like,
Thomas
is
for
that-
the
is that-
record. Oh.
Go ahead, Sean. Yeah.
Yeah, okay. Thank you for your question. Sean Thomas for the record. Regarding your question, we don't know the exact limit that's been used. Usually the only 2 things we're able to get from Suitor's data set is 1, if the substance was detected upon toxicology, and the second is if the coroner medical examiner ruled that it contributed to death. So typically in like opioid involved overdose deaths, if it was like an opioid like fentanyl and they had high levels in their system, they'd say it contributed, but we don't get that exact amount.
And the other thing, oh, sorry, go ahead.
No, I go, that like goes to my question, right? And like I have personal lived experience with this, with the loss of a brother, where it was a cocaine substance, but it had low level traces of fentanyl. So like if a person is using another substance, it doesn't take much of fentanyl to be in there to contribute to the OD, like it'll kill you instantly. So I guess that's where my question is. There's a testing, like you said, the toxicology report, or how the death reports go, where or data you can pull where it's just different substances, even marijuana. There's toxic in marijuana, and this is a trace amount of fentanyl to pull that data, because that's where, in my personal experience, I don't know any proper data, but in my personal experience, I've known several people now that have died from other substances, and it was trace amounts of fentanyl.
We do break the overdose data down by substance, but I'll just remind everybody that we have to wait for people to die to know what's killing them because of how we collect our data. We have no way to do confirmatory biosurveillance of the drug supply. That's a problem. We have to fix it. There's other states, other programs that have done really great things. Minnesota is partnering with their ERs to do to take excess urine drug screen on a non-fatal overdose to the state public health lab. But urine drug screen on a non-fatal overdose is not standardized in all hospitals. We also know that there could be field testing done. But we have to wait for people to die to know what's killing them and causing harm. And that can't be what we're doing anymore. It's got to change.
Thank you. Sorry about your brother.
No, thank you.
Thank you. All right, Ms. Lee.
Thank you, Lisa Lee, for the record. I agree with Elise wholeheartedly. We shouldn't be waiting until people are dying, or even to the non-fatal overdose point. Absolutely. My comment was related to Jessica Johnson's question. I had reached out to Dr. Laura Knight, who's our chief medical examiner and coroner, about the xylazine issue back in April. And again, same as Sean said, she said that there have been 2, one in 2020 and one in 2021. But also she said that there was one in the last 30 days, which again, this is back in April. She said it included xylazine, fentanyl, methamphetamine, morphine or heroin, and benzos. So again, like a lot of these overdose deaths are, derived from polysubstance use. So it's hard to tell what was the major contributor. Usually it's a lot of substances that are found in, the toxicology report, but 3 in the last 3 years. So xylazine isn't a big issue here yet, but it has come and gone in waves. I remember back in my day in San Francisco, xylazine was a big thing, and that was back in the 90s and early 2000s. And it's pretty bad stuff. So it's good to keep an eye on.
Thank you, Lisa. Okay, any further questions on this particular agenda item before we move on? Yes, Dr. Woodard.
Stephanie Woodard for the record. Thank you. It's not a question, but more of a statement. I just wanted to also express some appreciation for Sean and Elise and the work that they are doing. It was several years ago, actually, that the disconnect between information sharing and data sharing in a standardized way to do that between public health and public safety really became an issue and was identified as one of the core strategies that we needed to lean in on in Nevada. The way that this plays out pragmatically at a community level is that if you have individuals who are surviving non-fatal overdoses and EMS is detecting an increase at the community level, or emergency rooms are treating individuals and they're starting to see a pattern. If there is awareness that if they're seeing an increase, then that information should be shared in a standardized way with law enforcement. Then we can get word out on the street because perhaps there has been, I'll just use the term bad batch, occurring in our communities. Similarly, if there is the opportunity during some type of law enforcement action where they're removing drugs from our streets, but there's an indication that those drugs have actually penetrated into the drug supply on the streets, notifying our public health officials is going to be very important because they need to know that they have been able to detect that there are substances that are available on our streets, so that there is a heightened awareness. So really it is finding ways that there can be an exchange of information and data. Certainly having data sharing agreements and information sharing agreements is very important because we want to make sure that there's not redisclosure of critical information that could potentially hamper a law enforcement investigation. But aggregate information to be able to be shared can actually have a pretty profound impact. Where we've seen this work is if there are drugs, for example, I'll just use the example of a pressed pill that have been identified clearly linked to increases in overdoses occurring in a community. If law enforcement can share what that actually looked like with public health, then when harm reduction coalitions are going into communities where people are potentially using those drugs, they can alert them that they need to be on the lookout for certain substances. So, there are real implications for ensuring that we've got good relationships and open, transparent communication between law enforcement and public health for us to be able to intervene quickly and adequately at the community level.
Listen, I appreciate that. It's got me feeling some kind of way. And I mean, it just seems like we're too smart to not have figured this out or to, look, okay, let me be quiet. All right, thank you for the feedback on that. Okay, let me move on to agenda item number seven. Dr. Kearns will be giving us informational overview of overdose response spike plans. Dr. Kearns.
Thank you. Again, Terry Kearns for the record. And going back a number of years in 2018, 2019 timeframe, the Attorney General's office was awarded a grant for the ODMAP, Overdose Detection Mapping Application Program, that we then partnered with community members. There were 8 communities that we worked with. But prior to getting that grant, when we were in the process and applying for it, through some discussions with the Attorney General's office and DHHS, our thought was if we get something in our communities that shows us that we may be experiencing a spike, then we probably ought to have plans in place in what we're going to do. So to the point of some of the conversation today about data sharing, communications, those sorts of things, DHHS, through the statewide opioid response grant, pushed out a notice of funding, and every one of our communities did develop a community overdose spike response plan. So there would be a concerted effort between the groups that were identified by each community. It wasn't mandated. So each community decided who those community partners were. Through ODMAP, they had, through best practices that were being done throughout the country, they had a template that they put together as an overdose spike response framework that was provided to all of our communities as they were working on putting these different community response plans together. So the good news of this is that our communities have already worked on some of this and do have response plans in each of the communities. Many of them look similar. Some of them are a little different. Some of the communities are continuing to try to operationalize these response plans so that they're not, unfortunately, a plan that's sitting on the shelf.
Right.
Much of the work that was done was unfortunately really pushed to the back because of COVID and all of the issues surrounding COVID and the responses to COVID. But I will tell you that 2 of our communities took their community overdose spike response plans and did tabletop exercises with them to see where there were gaps or areas that they needed improvement, recommendations. And we had one community, which is one of our frontier counties, who actually did a full-scale exercise utilizing their overdose spike response plan, pulling in all the partners in there, from law enforcement responding to fire EMS all the way through to their hospital. So kudos to all those communities who've actually tried to exercise these. But really the main parts of the overdose spike plan are: who are the community partners, who are going to be at the table, who has the need to know from public safety, public health, our community prevention coalitions, treatment providers. And again, each community decided who that was at their level. Then each community had to look and define what a spike was. To Elisa's schooling on us on the rates and the counts, a spike is going to look different in each of our communities here. It will look very different in Las Vegas from what it is in Mineral County, for example. So then they were to just define what a spike was going to be. And this is suspected overdoses again. And then throughout that, it was what activities are going to be completed and who's going to complete those activities. So for the example that Dr. Woodard gave, if law enforcement is seeing pressed pills, what are they going to be doing? Trying to get those pressed pills off of the streets. And then our public health partners would be starting to do some of the harm reduction and working with the people who have not died from an overdose, but trying to prevent overdoses, getting naloxone out there, those sorts of things, as well as notifying fire EMS and our emergency departments of what's going on so they can be prepared. So these activities in the spike response plans looked at activities prior to a spike, during a spike, and then after a spike. And some of the activities that were discussed were, is there going to be communications pushed out? Who will be the main point of contact? The agreements between all of the different partners on who will be involved in that is one example. If naloxone is going to be distributed, who will be doing that? Are we going to have our fire and EMS and our law enforcement doing leave behind programs? Those sorts of things are the types of things that were in place. Next slide, please. So this is what the National ODMAC presented. This is just an example of the framework that I talked to you about that many of our communities used to develop their plans. Next slide. So this is the contents that were in that ODMAP framework. And like I said, each community took this and took parts of it, and they all do look slightly different. But this is kind of going down who all the partners are, those pre, during, and post activities that they'll be working on, and then looking at media and some of the appendixes. Next slide. So based on this model, what ODMAP did was they took this, this quality tool. It's a plan, do study act, and looked at this whole process. And this gets into the exercising that I talked about so that some of our communities have done. So you have a plan, you develop that plan using the framework. Then if a spike occurs, you deploy out during a spike, you evaluate that plan that was put in place, and then you adjust the plan as needed based on those evaluations. To date, for a number of reasons, we haven't had anyone who has activated their spike plan response plans at this point. But again, I think that's going to be a case of getting these plans, pulling them off the shelf, dusting them off, and putting them to action. Next slide, please. This is all of the communities, so it's every county and Carson City that has a plan. Again, they all look slightly different. Some of them look familiar. Who the lead agency was, because what we have found is, as you can see in Carson City, they took the approach of it being fire, EMS, law enforcement, and public health were their lead agencies. So they had multiple point of contacts. In Clark County, it was Southern Nevada Health District who became the lead for their plan, working with all of their partners. In Washoe County, it was Washoe County Sheriff's Office that was the lead and working with all of their partners. And you can see the majority of the plans, the lead was our Community Prevention Coalition. So a shout out to them for taking the lead and really moving forward. But I guess the long and short I want to tell you of this is we do have plans in place. Part of these plans is the topic of data sharing, whether there's actually been work on the data sharing and data sharing agreements is part of what should be looked at. I don't think that we have formalized plans yet under these, but it is a component that they should be looking at. So the good news is all of our communities have already worked on these plans. They have a template in place. They have the partners who were agreed on by each county of who those partners are that have signed off on these plans. So I think we need to just now take these plans and really get them back on the forefront and start to try to operationalize these plans. Next slide, please. That's my presentation. I'll open it to any questions.
Thanks, Dr. Kearns. Great presentation. Questions? None on the screen?
Dr. Woodard has a question.
Dr. Woodard.
Sorry. Thank you. Stephanie Woodard for the record. It's both a question and a comment. The first is that one of the other areas that we've identified along with the CDC and the DEA as an opportunity is to potentially reevaluate the overdose spike response plans to include an annex in the event that there is an interruption in the drug supply in a community due to some kind of law enforcement action with potentially a prescriber that was identified as overprescribing or some other way of diversion of substances into a community. Because essentially what will happen if some action is taken and it does take a prescriber out of the community who has been known to be overprescribing or proliferating prescription drugs into the community, is it will shrink the availability of that supply and can have some pretty harmful impacts in the community as well. So that's just been one other opportunity that I think we've identified over the last couple of years. And so in conversations with the DEA and the CDC and others, because we have the overdose spike response plans, we felt at least somewhat ready should there be an interruption in the drug supply, but recognizing that it is a slightly different issue. And so the actions will need to be taken that are different as well. So that was the comment. But the question to you, actually, to Elise and Sean, I'm hoping that they're both still on. I know your group was working to identify some thresholds that might be used to be able to identify a spike of overdoses in jurisdictions. I was just wondering if you could provide an update on where you are at with that, and then if those exist, if there has been a communication strategy to the local jurisdictions, or if that's still in development.
This is Elise for the record. So Sean, I'm going to toss it to you momentarily to talk about the syndromic surveillance work. But I will say, so this work is still in process, and we have been working on developing a plan to assess, and we're actually looking at spikes in syndromic surveillance. So that would be our ER chief complaint data. Sean can speak to thresholds specifically. But one thing I think we might want to look at, and I know that I'm kind of a little bit of a rock in Terry's shoe about this. We might just want to confirm some of the case definitions in ODMAP to make sure that the case definition that is pulling is not over pulling. Because we think in looking at our EMS data, we may be looking at our case definition may be pulling respiratory arrest as an or and not an and. So Sean, sorry, do you have anything to add on the syndromic surveillance spike response plan?
Yes, Sean Thomas for the record. So for these syndromic surveillance spike response investigation report, essentially I sit on a couple of national working groups that are trying to leverage syndromic surveillance as a way to rapidly identify some public health emergencies. And particularly here in Nevada, I've been focusing on looking at suspected drug overdose and suspected opioid overdose. Developing thresholds that are typically 1 or 2 to 3 standard deviations above an average that is typically seen on a particular day to kind of identify these spikes. So that's something we look at every single day in this system. We refine our thresholds, and we're still trying to develop more of a communications plan for that. But right now we haven't really seen any types of spikes in the system.
But the only other thing I'll add is when using that syndromic surveillance system, we're only capturing overdoses for people that made it to the ER. So there's other systems that we need to look at, including ODMAP, EMS. Hopefully we can get law enforcement data. I don't know what that looks like. So whatever the system looks like, there's going to be limitations across each of them. So they need to be looked at all together, not just syndromic surveillance, not just ODMAP, because syndromic surveillance is only capturing the people that made it to the hospital. ODMAP is only going to capture the people by which there was a law enforcement response and the data was entered into, or an EMS response and data was entered. So just one thing to think about. Thank you.
So if I can add to what Elise brought up, is ODMAP is used slightly different in each state. Currently here in our state, it is primarily EMS data that we are pulling, so it could be high. She is correct in that. However, and this is part of the plans, that if we did see a spike in ODMAP based on what has been labeled a spike within that community, it's kind of a bellwether or a red flag. Hey, you may have something going on. You need to start delving into some of your other data to see if it really is a spike. So it's just kind of like an early notification system. As many of you who have heard me speak, I've come to find that in this, real-time data means something very different depending on who you're talking to. So it's a real-time in terms of 24 to 72 hours from the time of a suspected overdose. The closer you are to that real-time, the less vetted the information is. So I would just add that.
So I'm gonna have to beg your indulgence and forgiveness. I thought we had a 4-hour time block, like we typically do for my SURG committees. We do not. And I have I've taken up all our time. We have 10 minutes left in this room. So I have to apologize. We won't be able to finish the entirety of this agenda. We will have to, at our next meeting, pick up on the remaining presentations and go from there. I really do apologize. Charges to my head, not my heart. I want to hear from everybody on everything. And I thought we were making a good clip there. So my apologies, everybody. Let's finalize this conversation on this agenda item, and then we will move to public comment and pick up the other presentations at our next meeting. Okay. All right. Any further comments on number 7? Yes, Dr. Woodard.
Yeah. So if you don't mind, thank you, Stephanie Woodard for the record. One of the reasons that we're in this room today actually is because there was what we would consider a spike in overdoses that occurred in a relatively short period of time down here in Las Vegas just about a month and a half ago now. And unfortunately, the majority of us that were notified by sort of a mass email without having the opportunity for that information to be disclosed in a way that we could have potentially taken action and contacted the point of contact in Las Vegas, Clark County to start implementing their overdose spike response plan. And so in other states where law enforcement is reporting directly into OD maps, if we were doing that here, we would have been able to gather that information and it would have been available through OD maps. And in its absence, because the overdoses resulted in fatalities that were not involved in the healthcare system, which is where most of our data is coming from for syndromic surveillance, it went undetected until we were all finally notified. So I bring that to your attention only because it really does show where the gaps are and how that can have a pretty significant impact on having a community that is in a readiness stance, that has an overdose spike response plan ready to go, that isn't able to take action because of that gap in communication and information.
Yeah, thank you for that. Any further comments, questions?
We have Debbie Nadler and Lisa Lee.
All right, we got a couple of comments, Debbie Nadler and then Lisa Lee.
Yep,
Ms.
real
Nadler.
quick, somebody mentioned the DEA, and I don't know if I heard wrong or not. Is the DEA involved in any of this mapping or planning? Because I was told, and it could be wrong, that the DEA was defunded here. Are they working out of LA now? Or did we just get rid of the DEA 360? Or do we not have the DEA working with us here anymore?
Go ahead, ma'am.
Jamie Ross for the record. The DEA 360 was a 1-year grant that Nevada had. So after that 12-month grant, that no longer exists, but the DEA still exists in Nevada.
Are they part of this information? Do they help with this information and this mapping or anything, or no?
No, currently the majority of the data in there is from EMS data. We do occasionally get law enforcement in a couple of counties that were entering data, but I will give you the example in New Jersey. It is all law enforcement driven, and they have a much more actionable plan where they are seeing spikes and are able to respond to their spikes.
Okay, thank you. Sorry. Thank you.
Yeah, Dr. Kearns is being polite. I must say there are certain law enforcement agencies that did not want to participate in the OD MAPS program, and that's why we have a may instead of a shall, so to speak. Let's just be clear about it. All right, that was Ms. Nadler. Ms. Lee.
Thank you, Lisa Lee, for the record. Just to respond back to what Dr. Woodard said about additional notifications when prescribers are, I don't know, busted. I don't know what a polite word is for that. But thinking about different conversations I've had with a group of stakeholders who use opioids specifically in Washoe County, one of the concerns I keep hearing is if my dealer gets busted, then I have to go to the unknown. And so I wanted to just put it out there that also when dealers, whether they're low level or high level suppliers are right, that also increases that risk profile as people have to seek outside of their current, their known network. And so then they're seeking a product that they don't know, and that is incredibly risky. So I don't know where that lands as far as this spike plan, but I also think that should be considered as increasing the risk profile of people who use drugs as they seek substances outside of their known network.
Interesting. Thanks, Lisa. Okay, last call for topics on questions on this particular agenda item.
Again, just real quick,
Yeah,
one
go ahead.
question,
Yeah.
maybe with her, because she mentioned, doctors, say if a doctor is prescribed, so prescribing whatever, but is there an emergency plan in place for if there's a, like you said, bad batch or a bunch of cocaine out there or meth out there and all of a sudden you see a spike because it was.
That would be in response, in the community response plan. It's not specific to drug. It's a plan that can be used for any of them, so.
All right. Thanks, everybody. I appreciate it again. Sorry about my bad timing. Mrs. Sanchez, I should have had you do the chairing. You probably would have got us all done. Sorry. Let us then move to agenda item number 12 for public comment and open it up. Do we have anyone who'd like to speak in public comment?
You have a Miss Lisa Hoover.
Ms. Hoover?
Okay. Hi. Thank you, Attorney
Hi.
General. You are right. There are a lot of smart people on this panel today, and the research that they have done is absolutely incredible. I approach this as a bereaved mom who lost a child to addiction. I have another son that is in active addiction, and we see it from a completely different perspective. I agree with Elise. We need to stop waiting for people to die to do something. Addiction is what leads to overdose. We need to tackle the problem of addiction as well. That's why rehabs are so important. We need to spend money on rehabs. There needs to be on-demand treatment. They need to be proper. They need to be long enough to help the person with the substance abuse problem. We need to educate law enforcement as well on this. The experience I had when my son passed away was absolutely horrible with the detective. He literally told me, it's too big of a problem. There's nothing we can do. When I asked him about the house in the neighborhood that the neighbors have been calling on for years, telling them that they're selling drugs there and nobody would bust them. They go over there, do little drive-bys here and there. My son dies and then they decide to go over to that house. But still, to this day, nobody in that house has been arrested. Still, the same activity is going on. His insensitivity to me when my son died is absolutely unacceptable. And he even said that this area is known as heroin highway, yet they do nothing to help. Addiction is the problem. Addiction is what we need to be treating, and then we wouldn't have these overdoses. And we need to look at the way the rehabs are run and how we treat them and get rid of the stigma. Thank you.
Thank you, Ms. Hoover. And again, we offer our condolences. Thank you so much for your public comment.
I believe we do have an Arnold Thomas.
Arnold Thomas, are you on? Next up for public comment. Arnold Thomas.
Yes, can you hear me?
Yes, go ahead, sir.
Yeah, Arnold Thomas, Vice Chairman, Shoshone Tribes of Duck Valley, Northeastern Nevada. For the
Hello.
record, I am a MSW chaplain, traditional healer, and elected official for our tribe. One question I have is regarding Elko County. Didn't hear a lot of discussion regarding Elko County. I know we've been impacted heavily in Elko County, so there was some mention regarding Lincoln, Washoe County, but regarding our tribe, our tribal nation, we do have an issue, a problem here, but we would like to, number one, find out who in Elko County we need to collaborate with. Secondly, will the presentations be shared via email regarding these presentations? Thank you.
Thank you, Mr. Thomas. So we can't respond in public comment to public comment, but what we can do is say someone will be reaching out to you afterwards, and we can get we can have a conversation with you around both of those issues. Okay.
Okay. Yeah. So as you're aware, Mr. Attorney General, we just met with the U.S. Attorney, Mr. Frierson. So we are a sovereign nation, and
yes, sir.
We're not a stakeholder, but we are a sovereign nation, and we would like to have more involvement in the solution. Thank you.
Absolutely. And we welcome your interactions with us, sir. Thank you so much. We appreciate it. Any further public comment from anyone? Okay.
Just that.
Yeah, go ahead. You said.
I just want to encourage everybody, because a lot of the talk and a lot of the issues can be solved by erasing stigma. You know, that's what kind of would help you. Some ways collaborate with schools or dividends, and so just encourage people to, if you're in recovery or you're a loved one that suffers in recovery, to talk about it. The more we talk about it, the less the stigma happens.
Yeah.
And so I just encourage everyone to talk about it openly, and you know, and verbiage. You know, a lot is in the way we talk. You know, so like, you know, we use different words like you know, person in long-term recovery, or you say, or you know, I lost a loved one to substance use disorder versus, you know, addiction. Those wording has a big impact on erasing stigma, or like a fentanyl poisoning instead of using the word of overdose as much. You know, different verbiages, and if we all encourage everyone to start talking like that, and talking out loud, or recovering out loud, or you know, sharing your story out loud as a family member, I think that goes a long way with erasing stigma.
Thanks, Giuseppe. Appreciate that.
I agree.
Okay, our next meeting is scheduled for December 13th this year. So please mark your calendars for December 13th. We will pick up on the agenda that we didn't complete this time. And with that, 10 o'clock? We don't know. Is it going to be? We don't know yet. Stay tuned. We'll let you know what time on December 13th, and I will be certain that I know how long we go too. So, okay. Thanks, everyone. We are adjourned.
Sorry about that. I didn't even think about it.